người ta về
Cristian, எனக்கு முடியல சார். நான் என்ன சார் பண்ண போறேன்? வலிகள் அதை வெல்ல யார் முடியாது. உள்ள இருக்கிற ஆளுநர் மொழியோடைக்கு சாகும் போது ஆனா நீ நினைச்சா ஒரு மொழியோட வெறிய மாத்த முடியும். என்ன சொல்றீங்க சார்? எனக்கு புரியல. நீங்க போய் எனக்கு புரிச்சோட மொழிய உயிரோட வாங்கிட்டு வாடா.
இது ஆஃப் பண்ணிடலாமா?
That is your view, sir.
யார் கையெழுத்து போடணும்? நான் சாட்டுன்னு என்ட்ரு போடணும் பார்த்தா எனக்கு என்ட்ரு போட முடிய சாட்டு வரல.
இது வந்துருச்சு இல்ல சார்?
Good afternoon, Sandil. Good afternoon, Dhiravim Mohan, sir.
Good afternoon, sir. Good afternoon.
Good afternoon, sir. Sandil, are you online? Dr. Sandil?
Sir. Good evening, sir. We'll start, sir.
Yeah, we'll start. We'll start with the Dhiravim Mohan, sir. Chandru will join.
Yes, sir. Yes, sir.
Okay. Good afternoon, all. On behalf of IMA CGP of Tamil Nadu, we welcome you for the 4th day of the state IMA CGP conference. The previous 3 days, we had a very good following. It was always around 800 to 900. All 3 days, our entire program was. So now I request our CGP state office bearer, Dr. Rajesh Sengodan, sir, to give his words, to give the IMA prayer and physician's prayer. Dr. Rajesh, sir. Dr. Rajesh, sir, are you online?
Yes, sir. Sir, kindly unmute, sir.
So kindly unmute, sir.
Yes, sir.
Yes.
Thank you, sir. Thank you. So, IMA prayer. எல்லோரும் மகிழ்வுடன் வாழ, எல்லோரும் நலமுடன் வாழ, வலி என்னும் தொல்லை நீங்கி, அல்ல செய்யும் இன்னல் நீங்க, பேராசை பிரதிபயன் அகற்றி, பிணி போக்கும் பெரும் பணியாற்றுவோம். Physician prayer. எல்லாம் வல்ல இறைவா, உலகின் சிறந்த மருத்துவன் நீயே, உன்னை மண்டியிட்டு வணங்குகின்றேன். உன்னிடமிருந்து நல்லதும் சிறந்ததும் என அடைய பிரார்த்திக்கிறேன். எனது கரங்களுக்கு திறமையை தாரும், எனது மனதிற்கு தெளிவான பார்வையை தரும், இருதயத்துக்கு இரக்கத்தையும் கனிவியும் தாரும், எனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் வண்ணம் வாடும் மக்கள் படும் பாட்டினை சிறிதளவு போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையும் தாரும். என் மனதிலிருந்து தகாத எண்ணங்களையும் உலகளவு ஆசையும் அறவே நீக்கி பணி செய்திட அருளுமாறு உன்னை சார்ந்து வேண்டுகிறேன். Thank you, sir.
Thank you, Dr. Rajesh, sir. Now
you,
I request our CGP IMA State Branch Chairman of Studies, Dr. Sandil, to give his welcome address.
Thank you, sir. I welcome all our faculties today and all the participants. So this is day 4 of CGP conference, and today's theme is about respiratory medicine. So the entire session is going to be coordinated by Dr. Nandagopal sir and also Dr. Bomusamy sir, and we have our moderator, Dr. Jayamohan Unnidan sir. So without dragging much, we will go to the session directly. And now I request felicitations to be done by Dr. Dhiravim Mohan sir, Joint Secretary, CGP Headquarters.
Good evening, all. Respected Dr. Sendil Kumar, IMA CGP Director of Studies and Joint Secretary, IMA CGP Headquarters, my good friend and Secretary, Dr. Anand Sukalingam, and all the office bearers of IMA CGP Tamil Nadu State Branch. I congratulate all the members for the excellent academic fees for the past 3 days, and today being the 4th day of CME. I am also happy to see that on all 4 days, all the IMA leaders were there to felicitate
and they have expressed the happiness about the activities of IMA CGP Tamil Nadu State Chapter, and all the credit goes to Sendil Kumar and Secretary Dr. Anand. Once again, congratulate them on the steps taken to promote CME, where you can have 5 credit points even when you are at home, and you can earn 5 credit points. That is very, very important. And also wish the team good luck and best wishes for today's CME on respiratory medicine. And also apologize to them for not able to attend the physical meet tomorrow, and wishing the function success. I don't want to much go into the, don't want to waste time, and just go on to the respiratory medicine, the CME. Once again, wishing you good luck. Thank you, sir. Thank you.
Thank you, sir. Now we have our West Zone Vice President, Dr. Chandrasekhar sir, to give his felicitations. Kindly proceed, sir.
Good evening to all. ஆக்சுவலாக சிஎம்இ வந்து இப்போ இருக்கக்கூடிய பேட்ச் வந்து ரொம்ப நல்ல லெவலில் பண்ணிக்கிட்டு இருக்கு. ஐ விஷ் வெரி சக்ஸஸ்ஃபுல் சிஜிபி ஆஸ் அ ஃபியூச்சர். அதே மாதிரி இந்த பீரியட்ல வந்து தே ஹவ் டன் லாட் ஆஃப் ரீஃபார்ம் ஒர்க்ஸ். அதில் வந்து சிஜிபியில் வந்து மெம்பர்ஸ் மற்ற இது எல்லாமே. ஸோ ஐ கங்க்ராச்சுலேட் ஒன் அண்ட் ஆல். Thanks for the opportunity.
Thank you, sir. Anand sir, now we will proceed.
Thank you, Dr. Thank you, sir. Thank you, Dr. Duraimohan sir, and thank you, Dr. Chandrasekhar sir, for your felicitations. Now I request Dr. Jayamohan Unithan sir and Dr. Nandagopal sir to take over the forum, and we can start with this, sir. The stage is yours, sir.
Good evening, everyone. Good evening. Today we have a program on respiratory medicine. Respiratory medicine, as lungs, you know, is very important, which gained momentum after the COVID epidemic. Anyway, there are a lot of things we know about lungs, about the diseases in the lungs, but there are a lot of things which we don't know. And there are a lot of things which are coming new, and newer things are evolving. So without much ado, I think Dr. Venugopal is there. He will be speaking. Dr. Venugopal is a consultant pulmonologist, very active in interventional pulmonology. He is the lead interventional pulmonologist in KMCH. And he will be speaking on clinical pulse in pleural effusion. Pleural effusion is simple. Once upon a time, when I was a PG student, I was taught that unless otherwise proved, pleural effusion is tubercular. That dictum has gone. Pleural effusions can happen because of many diseases in the body. And I welcome Dr. Venugopal to please present his clinical pulse in pleural effusion. Dr. Venugopal, please. I think Dr. Venugopal is there.
Sir, is Dr. Venugopal available? And he has to be made the co-host also.
If he is not available, we will pass on to the next topic. Let him come and join later. Is it okay?
Yes, sir. It's fine with me.
Yeah, okay. In that case, we all know oxygen is, or pranavayu is one of the important things. It can be poison. If you give in excess, oxygen can be poison. Oxygen can kill also, but oxygen saves life. Our life depends on oxygen. But so oxygen therapy has come to stay, and it is an important landmark in important aspect of pulmonary medicine. And for that, to talk on that, we have none other than the known and famous consultant, Dr. V. Nandagopal, who is a consultant pulmonologist with Hindustan Hospital at present. He has many accolades in the field, Like he has been a gold medalist. He has worked as a consultant in GKNM Hospital, and right now he is one of the lead chest physicians or pulmonologists in Hindustan Hospital. I hand over the podium to Dr. Nandagopal for oxygen therapy. What, when, and how? Welcome, Dr. Nandagopal.
So, good evening, sir, and thank you for those glowing words. I also thank all the organizers, particularly Dr. Senthil, with all his enthusiasm, organizing events with the whole team, one after another, and brought CGP to the current level. I think it will still go to further heights. Without wasting much time, I think I'll straight away go to the topic. Just let me know whether you are able to share, whether you are able to see the screen. Share screening. I need to go to, yeah.
What happened, Nandagopal? What happened? There is a total silence.
I suddenly lost contact. I started sharing the screen, got lost.
Okay, I'll wait. We have some technical issues.
Yep. Can you see the screen now?
No. Yeah, it is going to start. I can see has started screen sharing.
Yes, sir. Multiple tiles you're seeing.
No, not yet.
I'll just
It's buffering.
go to the presentation. Yeah. Can you see the screen now, sir? With oxygen therapy?
No, nothing is coming on the screen. It is buffering. No, he is Nandagopal reads, not me.
Sir, is there an oxygen therapy screen on your screen right now?
I am not seeing anything. I'm only seeing Dr. V. Nandagopal V has started screen sharing.
Oh, anybody else, if they can give a feedback?
Anyone else can give a feedback whether they are seeing the screen?
Sir, screen is the loading.
Yeah, it's only buffering.
Yes, so the loading of the screen, sir.
Oh, it's still loading.
Yes, sir. Yes, sir. Maybe network problem.
Yep. So how do we correct this?
Be the host and send it to me. I will try sharing for you.
Sir?
Can you send your PPT to me and give me screen sharing? Let me try. Of course, our technical expert Nandagopal ke varlane எனக்கு வராது, but let me try. Maybe I am sitting in a different room. Maybe that may help.
So you check the network, sir.
Okay. இல்லம்மா இங்க
Probably he's trying to rejoin.
Sir, what about first presenter, sir? Venugopal, sir?
Dr. Venugopal, are you present here? I don't know. I can't. No, he has gone out.
Sir, is his full name Venugopal Pukalendi, sir?
J. Venugopal.
Yeah.
J.
Okay, I'll find out, sir, whether he's. No, sir, he's not online, sir. Venugopal Pukalendi is online, sir, not J.
I'll give him a call on phone.
Is anyone ready, sir, apart from these two?
There is Dyspnea for Evolution. Prabhuram, are you there? Prabhuram from TMF Hospital.
One Prabhuram is online, sir, but I don't know whether.
Yeah, it must be. Can you talk to him?
I'll find out his number, sir, if it is a.
One another speaker, Srikanth, sir.
Srikanth is here. He is here.
So then we can start with him, no, sir. We have 3 hours, no, sir. Instead of wasting time, can we?
நான் ஸ்டார்ட் பண்ணிக்கலாங்களா?
Yeah, we
Yes,
can
sir.
start now.
Yes, sir. Screen is displayed, sir.
Screen is displayed. Yeah, let me put this screen is coming through. Only
Yes, sir.
Yeah, I can see you.
Sir, can you see the screen now?
Yeah, I
Yes,
can
sir.
see
Yes,
the
sir.
screen.
Very
Go
well
ahead.
seen, sir.
Yes, sir.
Yeah.
Yes, sir.
So
Institute of Long.
Care group. Yeah, I'll just
Yes, sir.
change it.
Yes.
Just see whether it's coming through also. Oh, there is some. Next slide is not. Yeah.
Yeah.
Next slide
Yes, sir.
change also
Oxygen
happened.
therapy.
Yeah, oxygen therapy. Okay. I think. Sorry for the technical issues. With technology, we know that it's not in our hands also. Good evening and welcome once again to everyone. I think you're also able to hear me.
Yes, sir.
Yes, sir.
Yeah. So let me go into the oxygen therapy, what, when, and how. I'll initially put this objective of this talk as let's understand the reasons for recurring oxygen therapy, to understand the oxygen equipment and delivery systems, and how to administer oxygen safely. So oxygen is like any other drug we need to give. So let me just put out few clinical case scenarios before going into the topic. These are all real patients who came to us at one point or other. First is a 79-year-old female diabetic who's morbidly obese, admitted with respiratory infection with breathing difficulty in a conscious state. But she also had cardiac issues, so she was given a provisional diagnosis of LV failure, started on medications. We thought it's like initial thinking on the part of the admitting doctor was, at the night, it was a case of respiratory infections precipitating a LV dysfunction, going in for an LV failure, pulmonary edema, started on medication. Since she had breathing difficulty, she was also given a oxygen 15 liters via non-rebreather mask. The duty doctor was considerate enough to see it should be a non-rebreather mask. But morning, I mean, that night when immediately after the administration of oxygen and the initial medications, vitals were stable with oxygen also reaching 96%. Then overnight, the patient was on that, and morning when the staff went and woke the patient up, she had a reduced GCS. So Corey COS. So this was the scenario, the clinical case scenario. Let me begin with this and let me just go into the second case scenario straight away. It's a 75-year-old male, cervical myelopathy patient, also needs oxygen, so on home oxygen treatment, had a LRTI, cough with increased breathing difficulty, so increased oxygen support with other added medications like antibiotics, bronchodilators. The patient was admitted at hospital with the reduced GCS of 9/15. So again, reduced consciousness. What is the reason? We will come to this. Dr. Unithan sir already talked about this. So 86-year-old female admitted with pneumonia, hypotensive, myoclonic jerks, bounding pulse, on 10 liters oxygen via a non-rebreather mask since admission. So oxygen saturation is 97. The ABG is showing a pH of 7.03, respiratory acidosis. Oxygenation PO2 is 126 and PCO2 is 96. So all these cases were given oxygen. That is the common link between the cases. So let's think about that. Oxygen is the probably the most common drug to be used in the care of patients who present with medical emergencies, not just in the movies, in our real life also. So emergency department teams are likely to give oxygen to virtually any breathless patient and to a large number of patients with even other conditions like ischemic heart disease, sepsis, or even trauma. So let's go into the basics of oxygen. The normal daytime hemoglobin oxygen saturation is 96 to 98% in young adults in the seated position at sea levels. That's a lot of conditions apply, right? But the lower limit falls slightly with age and is about 95% with adults aged more than 70 years in normal adults. All the subjects, all patients have, not patients, all humans have transient dips in oxygen saturation at night with the even it can go up to 90% even in a healthy patients in all age groups. So please remember that in oxygen saturation will go down at night, right? And how do we measure oxygen? If this is measured directly from the oxygen saturation, which is directly from an arterial blood sample, it is called the oxygen saturation or SaO2. See the small a there. If the measurement is calculated from a pulse oximeter, which we all commonly do as practitioners, it is called the SpO2. Alternatively, we can also measure the oxygen tension of the blood again with the help of an arterial blood gas, which is known as the partial pressure of oxygen in the blood. This is known as PaO2 small a. So from this, you will be able to see that these three are totally different scenarios, different nomenclatures, not just by small letter change. They denote different things. One is a arterial oxygen saturation, SaO2. Pulse oximeter, peripherally, what we measure is SpO2. Then the oxygen tension, which is measured as PaO2, which can be either represented in kilopascals or in millimeters of mercury. So oxygen, when it goes below this 90% mark, when we say oxygen should be administered. So oxygen is administered for three main indications if we broadly classify them into three. One is to correct hypoxemia. Second is to ill patients who are sick in case they might become hypoxemic. But in reality, what happens is a very high proportion of medical oxygen is administered because most clinicians believe that oxygen can alleviate breathlessness. So whatever the cause of dyspnea, we give oxygen. Deaths can be due to both underuse and overuse of oxygen. Please remember death. Excuse me. Critical illnesses requiring very high levels of supplemental oxygen include cardiac arrest or resuscitation. Definitely yes. Patients in shock, sepsis, major trauma, drowning, near drowning, anaphylaxis, major pulmonary hemorrhages, major head injury, and carbon monoxide poisoning. These are cases where very high levels of supplemental oxygen are needed. But there are cases where the illnesses or the diseases may be very serious and they require moderate levels of supplemental oxygen, but only if the patient is hypoxemic. So acute hypoxemia, obviously patient is hypoxemic, acute asthma, pneumonia, lung cancer, post-operative breathlessness with hypoxemia, acute heart failure with hypoxemia, pulmonary embolism with hypoxemia. So serious illnesses, continuing pleural effusions, pneumothorax, deterioration of lung fibrosis or other interstitial lung diseases. Wherever the patient is hypoxemic, we have to give moderate levels of supplemental oxygen. Severe anemia and sickle cell crisis, again, require moderate levels of hypoxemia. So there are conditions where the patients need to be monitored very closely, but oxygen therapy is not required unless the patient is hypoxemic. So myocardial infarction, see even the cardiac, like what we call the acute coronary syndromes, and stroke, pregnancy and obstetric emergencies, hyperventilation or dysfunctional breathing, many poisonings and drug overdoses. Except for carbon monoxide poisoning, you don't need to give oxygen unless the patient is having hypoxemia. even in poisoning with paraquat or bleomycin, where the patients will eventually develop hypoxemia, you don't start with oxygen, because in that condition, the worsening, the respiratory fibrosis can worsen with increased oxygenation. Metabolic and renal disorders and acute and subacute neurological and muscular conditions producing muscle weakness, if you give oxygen in excess, they may be detrimental. There are certain conditions which are requiring either controlled or low dose oxygen therapy. COPD, exacerbation of cystic fibrosis, chronic neuromuscular disorders, chest wall disorders, and morbid obesity are these are the basic conditions you have to remember, where we have to give oxygen in a very controlled way, or we have to give what we call as a low dose oxygen therapy. So what is the basic goal of oxygen therapy? It is to maintain adequate tissue oxygenation while minimizing the cardiopulmonary workload. So this is the basic goal. When we, in working with this in mind, the need for oxygen therapy should be assessed by monitoring of ABG, which is not always possible in a peripheral setting. So we need to go by either clinical assessment or by a pulse oximeter. So when we take stock of ABG, a PaO2 of 60 is corresponding to a pulse oximetric reading of 90. So as here mentioned here, PaO2 less than 60 is a strong indicator for oxygen therapy. So here we have compared the oxygenation levels in ABG with skin findings. Like 80 to 100 will be normal, 60 to 80 will be cold, clammy extremities, less than 60 cyanosis will start setting in, maybe a little difficult to appreciate in our people, less than 40 mental deficiency and memory loss, and less than 30 bradycardia and cardiac arrest. So any PaO2 less than 60 is a strong indicator, but this PaO2 less than 60 is a ABG findings. So how do you correlate? An SpO2 of 90 or less is a strong indicator for oxygen therapy. So with that, we have to think any patient who's coming in, who's having an oxygen saturation, let's say more than 90 or more than 94, whatever the serious other illnesses is, we have to monitor the patient, but we need not start the patient on oxygen therapy, more so if the patient is having a saturation which is higher than 94. But we need to continuously monitor the patient for oxygenation. So how do you clinically assess hypoxia? So we can basically differentiate between mild to moderate hypoxia and severe hypoxia. CNS, restlessness, little disorientation, lassitude, and headache are common signs in mild to moderate hypoxia, where the restlessness will become a somnolence and confusion. The disorientation will actually become confusion and impaired judgment, loss of coordination, and worsening mental status. These are signs of severe hypoxemia. Cardiac-wise, you will have a tachycardia, mild hypertension, peripheral vasoconstriction as findings when the patient is presenting with mild to moderate hypoxia. But if the patient is having low oxygen and if the patient is having bradycardia and hypotension, that means it's a severe hypoxia which we need to act immediately. Respiratory, the symptoms are going to be the same: dyspnea, tachypnea, with shallow and labored breathing. With increasing dyspnea, increasing tachypnea, even possible the patient can tire out and have bradypnea as a finding in patient with hypoxemia. Paleness, cold, clammy skin is a finding in mild to moderate hypoxia, where the cyanosis will set in for severe hypoxemia. So if you can assess it clinically and have a pulse oximeter, you will be able to find out most causes of hypoxia, and you can even classify them into severe and mild to moderate. So here I need to just keep a mention on carbon dioxide. Although we are talking about oxygen therapy, carbon dioxide, we need to just mention carbon dioxide. Please remember, it's a vasodilator. So patients with hypercapnia may develop headache. carbon dioxide in high concentrations has hypnotic effects, and patients with hypercapnia can progress from drowsiness with flapping tremor to even confusion to even coma. A study of 127 episodes of acute respiratory acidosis showed that the best clinical predictors of respiratory acidosis. See, I'm talking about how we can detect a respiratory acidosis, which is basically an ABG finding clinically with the drowsiness, flushing of skin in a patient who's having a COPD, or if there's a presence of intercostal retraction. Just by observation, just by assessment, we will be able to find out whether the patient is having hypercarbia or not. So what are the clinical signs of high carbon dioxide? Carbon dioxide retention include a vasodilation, which will produce flushing and warm peripheries with dilated blood vessels, including retinal veins. But just remember, it's flushing and warm peripheries. Bounding pulse, drowsiness, flapping tremor, confusion, and coma. These are all signs of progressive carbon dioxide retention. So just keep this in mind, because one of the complications of oxygen therapy is carbon dioxide retention. We will come to this a little later. So monitoring any patient presenting with severe illness, we have to monitor for hypoxemia, and we have to correct hypoxemia at the earliest, which we can do with the help of pulse oximetry. And if the facilities are available, then ABG with pH and PO2 and PCO2. If ABG technically is not feasible, then even we can monitor continuously with mixed venous blood oxygenation also. So with this, the clinical assessment of need for oxygen is complete. Let's just go into the practical aspects of oxygen therapy. That's when, what, and how. We just see, we just completed the when part, then we'll go what and how next. See, oxygen is stored in 3 ways: cylinders, liquid oxygen, and oxygen concentrators. Oxygen concentrators are nothing but it's not storage device. It just takes the environmental oxygen, concentrates them, and gives to the patient at a desired level. Cylinders, compressed gas, every one of us would have known that from our MBBS days. But liquid oxygen, all of us heard liquid oxygen for a very first time, or maybe some anesthetist would have heard it earlier. With the advent of COVID, when liquid oxygen was not available, so the hospitals were running out and the oxygen tankers were running in here and there, and being stopped at the origin points, with the states not giving to other states. Like, all these problems came up during COVID. So basically oxygen storage is with one as a liquid oxygen, second as cylinder, but the patients do have the option of getting them from oxygen concentrators. These are storages and provision. So how do they deliver it to the patient? Patient delivery methods and interfaces are very many. We need to judiciously choose this also. So we need to very, very judiciously choose this. What is the method of interface we are going to keep on a patient? There are, like, I'll just go through that. So you can start from nasal cannula, which is a simple tubing with 2 protrusions into each nostril, which are delivering oxygen. Okay, so it's a simple face mask. It could be just a simple face mask. It could be a high concentration reservoir mask, which is otherwise known as NRBM, or non-rebreathing mask. Okay, so it's a oronasal face mask with exhalation valves, which are unidirectional. So whatever is the patient exhales, it goes out into the environment. It doesn't come in, but the air will not come in from the environment. It will come only from the inspiration valve, which is again unidirectional. So the oxygen feeding line, you can see that, which goes into the oxygen feeding line from either from the cylinder or from the central oxygen supply. It goes into the oxygen reservoir, and then from the reservoir through the unidirectional inspiration valve, the patient is able to take the breath in with more concentrated oxygen, and whatever the patient is exhaling is vented out into the environment through expiration valves. So the oronasal face mask, it is there, and it needs to be fitted slightly snugly, not too tight, not too loose, to make sure that maximum oxygen is reached into the patient. So the next is the Venturi mask. It takes the Venturi Bernoulli's principle. Venturi gives different range of concentrations of oxygen at different flow rates. You can see there are 5 or 6 color-coded devices which all look very, very similar. They all attached to the oxygen tubing, and the delivery oxygen from the oxygen reservoir, it is connected. So it can be from 24% with 4 liters oxygen to 60% with 12 liters oxygen. So 12 to 15 liters, in fact. So it is basically, it takes care of the oxygen delivery in a very particular way, in particular concentration. In patients who are having tracheostomy, it's used as tracheostomy masks, and it can be used as tracheostomy hoods are also given. In pediatric age group, we can see the helmets and masks and covers which are there. The flow meter, which needs to be showing the correct setting to deliver oxygen at a rate. So here it is showing 2 liters. So the ball has to be in the middle of that. The middle of the ball has to be in the line to say it's 2. So you can see the diagram C, which is showing the ball exactly at the middle of the 2 line. So that is when it is showing 2 liters. So it can't be above or it can't be below. So it is not a correct setting. So this is how it needs to be set. When somebody says you need to set at 3 liters, the middle of the ball has to be at the line exactly denoting 3 liters. So this is the correct setting. And there is a large volume nebulization based humidifier, which again has, you can see on the top of the storage container, it shows a 28 and 5 in which an arrow is pointing out. That means there is a 5 liters oxygen which is flowing through, delivering at 28%. So this is a large volume nebulization based humidifier, which also is given for particular concentrations of oxygen. So this is next. The first part we have looked at as of the oxygen storage, then the oxygen delivery. So oxygen delivery systems are basically classified into design based and performance based. In design based, they can be classified as low flow system, reservoir systems, high flow systems, and enclosures. Performance based, they can be fixed and variable. I don't want to go into very much technicality into this, but please do understand that gas flow is insufficient in a low flow system to meet the patient's peak inspiratory and minute ventilatory requirement. So oxygen provided in a low flow system is always diluted with atmospheric air. So the FiO2 will vary always with the patient's ventilatory pattern. You may be giving the same 2 liters oxygen. For certain period of time, it may be going in as 21%. For certain other period, it may be going as 24% oxygenation. So it is a variable performance device. So this is one of the oxygen variable performance devices. Nasal cannula is a variable performance device. High flow system, any high flow system, the gas flow is sufficient to meet the patient's peak inspiratory and minute ventilatory requirement. That means if the patient is taking in 10 liters of air per minute, the flow system itself will be able to provide that 10 liters. So in that way, what happens is FiO2 is independent of patient's ventilatory pattern. Whether the patient is taking 5 breaths, whether the patient is taking 15 breaths, whether the patient is taking a shallow breathing, whether the patient is taking a deep breathing, FiO2 is what you fixed. So it can deliver low to moderate and fixed FiO2. It's a fixed performance device. Reservoir system, basically like non-rebreather mask, stores the reserve volume of oxygen, either that equals or exceeds the patient's tidal volume. It delivers moderate to high FiO2, but again, it depends on the amount of the oxygen or minute volume the patient is able to take in. So it's a variable performance device. So to provide a fixed FiO2, the reservoir volume must exceed the patient's tidal volume. I'll give you a small example. Let's take the non-rebreather mask. With non-rebreather mask, we set at 15 liters oxygen. So when the 15 liters oxygen is set, the tubing is going to provide 15 liters of oxygenation per every minute into that reservoir. So if patient is taking only 6 liters of oxygen, that becomes a fixed performance device. At the same time, let's say we are giving only 4 liters of oxygen. So the patient's intake won't be met by the reservoir bag alone. It has to be coming in from the side of the mask also. So that way it will become a variable performance device. That is what it means. Okay. So then how to judge the performance of an oxygen delivery system? How much oxygen is the system delivering? Does the FiO2 remain fixed or varies under changing patient's condition? Of course, it varies, right? So it all, to put it very simply, low flow systems are variable performance, high flow systems are fixed performance, reservoir systems are variable performance devices. So low flow, nasal cannula, nasal catheter, and transtracheal catheter. Reservoir systems, reservoir cannula, simple face mask, partial rebreathing or non-rebreathing mask, and tracheostomy mask. High flow, only Venturi mask with Venti mask with aerosol mask and TPs with nebulizers. So these are how it divided. So let's take for simplistic purpose, we will use for only few things. We will use nasal cannula, we will use a simple face mask, we will use a NRBM, non-rebreathable mask, and we are going to, if at all we are going to use it, we are going to use a Venturi. We are not going to go beyond that. Just make sure that you know what you are giving. That's as simple as that. Why we need to know is there are complications of oxygen therapy. Let me just put it this way. Every drug has a side effect. Oxygen is a drug, so it has a side effect. What are the complications? Why the complications comes? These are audits from UK, not from India. So we consider NHS as a much advanced system. So, but this is the findings. Doctors and nurses have often a poor understanding of how oxygen should be used. Oxygen is often given without any prescription. Wait, does oxygen need a prescription? That's news to me. Okay. If there is a prescription, it is unusual for the patient to receive what is specified on the prescription. சரிங்க, நம்ம இப்படி யோசிக்கலாங்க. ஒரு பேஷண்ட் வர்றாங்க, நம்ம கிளினிக்ல இல்ல, நம்ம ஸ்டாஃப் ஃபோன் பண்றாங்க, சார் பேஷண்ட் ஃபீவரோட வந்திருக்காங்க, பேராசிட்டமால் கொடுக்குமா? The next question will be, சார் எப்படி சார் கொடுக்கறது? இன்ஜெக்ஷனாவா சார், இல்ல டேப்லெட்டாவா சார்? அப்ப அடுத்த கொஸ்டின் கேட்போம், சார் எவ்வளவுமா காய்ச்சல் இருக்கு? 104 டிகிரி இருக்கு, அப்ப இன்ஜெக்ஷன் கொடுத்துடலாம். நெக்ஸ்ட் கொஸ்டின், ஆமா ஐவியா கொடுக்கறதா சார், ஐஎம்ஆ கொடுக்கறதா? ஐவி இன்ஃபியூஷன் போடணுமா, ஐஎம் கொடுக்கறதா? சரிம்மா ஐவி கொடுத்துடலாம். சார் எவ்வளவு டோஸ் சார்? Next will be, patient எவ்வளவு weight இருக்காங்க? If the patient is a young child who has come with the fever, obviously it is going to be much lesser. If the patient is an adult who is going to be 60 kilos or something, then you're going to 1 gram infusion கொடுக்கமா சொல்ல போறோம். So it is even for a simple paracetamol, we have to have which way we are going to give, how much dose we are going to give, what is the duration or what is the method of entry. So similarly, even for oxygen, there needs to be a proper prescription, and then we need to ensure that the patient is getting the oxygen in that particular way. So that's why we are talking about variable systems of deliverance. So please remember and understand, oxygen is dangerous. So what are the complications of oxygen therapy? Oxygen toxicity, depression of ventilation, retinopathy of prematurity, absorption atelectasis, and fire hazard. Let's go through quickly in this. I think I'm hopefully not exceeding my time. Primarily affects lung and CNS. 2 factors, PaO2 and exposure time. CNS O2 toxicity occurs on breathing oxygen pressure at more than 1 atmospheric, which comes with the ventilators and other high pressure devices. Tremors, twitching, and convulsions can come because of giving too much oxygen. And please, if you are giving oxygen for a prolonged period of time, patients can develop acute tracheobronchitis, cough, substernal pain because of oxygen itself, and ARDS-like state. It's an irony, but yes, for ARDS, we need to give high oxygen level, and because of oxygen, patients can develop ARDS. It's going to be a vicious cycle. If there's a O2 toxicity, there is going to be an increased shunting, then there is going to be low PaO2 when we do measure with the ABG, or low SpO2 when we measure with the pulse oximeter. We are going to increase the oxygen and increase the percentage of oxygen. It's going to result in more toxicity. So that's going to become an endless cycle. So that's the problem with oxygen. So how much oxygen is actually safe? 100%, not more than 12 hours, 80%, not more than 24 hours, 60%, not more than 36 hours. The goal should be to use the lowest possible oxygen compatible with adequate tissue oxygenation. So there is a concept here, couple of minutes. Indications for 70 to 100% oxygen therapy is only during resuscitation, periods of acute cardiopulmonary instability, and patient transport. So what can happen with increased oxygen giving? It's seen usually in patients with COPD, with chronic hypercapnia, increased PaO2, VQ mismatch, and it can result in increased dead space with tidal volume ratio. It can cause increased carbon dioxide narcosis. So it also increased oxygenation, suppresses the peripheral chemoreceptors, which depresses the ventilated drive, resulting in. So please, you don't have to remember the mechanism, but please remember increased oxygen in excess will result in increased carbon dioxide also. So coming back to our first patient, overnight reduced GCS, overnight oxygen was given, the morning ABG showed the oxygenation was fantastic, 97%, but the ABG showed PCO2 of 85, which is much higher than normal. All that we did was to remove the oxygen and woke up after a few hours normally. So this is first. Okay, so oxygen is prescribed with a target SpO2 of 88 to 92% in such patients. You heard here first. Remember the term target SpO2. Sir, BP க்கு மாத்திரை கொடுக்கிறோம், சுகருக்கு மாத்திரை கொடுக்கிறோம் அப்படின்னா we'll have a target in mind. So even for giving oxygen, we'll need to have a target in mind. That target in wherever patients who are possible to go in for hypercapnia, the target SpO2 should be 88 to 92. So the clinical case 2, again, the PCO2 was very high, improved with controlled oxygen between 24 to 28%. The case 3, admitted with pneumonia, hypotensive myoclonic jerks. The patient itself had PCO2 96 and given 10 liters oxygen. So minimal improvement with reduced FiO2. This patient did not improve. So we had to suggest NIV in the ICU. So she's not a case with the 86-year-old, not a case for invasive ventilation. So just giving oxygen can tilt the balance completely and make somebody's life much worse. And this patient did not make it basically. So the retinopathy of prematurity, yes, it is in premature or low birth weight infants who receive supplemental oxygen. This can happen. There is something called an absorption atelectasis with 100% oxygen. So I'm not going too much into that. This denitrogenation can result in oxygenation. And there is, please remember, there is always a fire hazard with oxygen. High FiO2 increases the risk of fire. So preventive measure, lowest effective FiO2 should be used. So the use of scavenging systems, and with high FiO2, we cannot use a cautery. We need to be very, very clear. So please remember, oxygen is a drug. When appropriately used, it's extremely beneficial. When misused or abused, it's potentially harmful. Sir, please give me 5 minutes.
Yeah, go ahead.
Emergency oxygen use in adult patients, we need to be prescribed by target oxygen saturation, keeping SpO2 within normal limits, strictly no 100% oxygen, no 100% SpO2. Target SpO2 should be between 94 to 98% for most patients, and that target should be reduced to 92 to 96 if the patient is above 70 years. So target SpO2 in patients with COPD or those who with more morbidly obese who are at the risk of hypercapnia or high carbon dioxide should be at 88 to 92%. This is the one of the take-home messages is have a target SpO2 in mind. So aims of emergency oxygen therapy is to correct or prevent potentially harmful hypoxemia. So PaO2 of 60 or SpO2 of 90 is enough to prevent that potentially harmful hypoxemia. To alleviate breathlessness only if the patient is hypoxemic. If there are a lot of cases of breathlessness without hypoxemia, there is no point in giving oxygen in such patients. So indications for emergency oxygen, again, SpO2 should be less than 94, should be 88 for hypercapnia. Critical illness, yes. and carbon monoxide poisoning irrespective of SpO2. So too much oxygen can be harmful. Risk of hypercapnia in selected patients, constriction of coronary arteries, constriction of cerebral arteries can happen. So resulting in increased mortality in survivors of cardiac arrest and increased mortality in non-hypoxic patients with mild to moderate stroke. So it is not just COPD, even in patients with CVS or CNS illnesses have to be given oxygen at a targeted level. So patients with risk of hypercapnia, please, it's not all COPD patients. COPD, morbid obesity, neuromuscular weakness, chest wall deformities, reduced conscious level patients, all these patients can potentially develop hypercapnia, particularly patients who are on morphine or other respiratory sedatives. So you need to be very, very clearly demarcate them. So how oxygen should be delivered? If the patient is critically unwell or severely hypoxemic, then use an NRBM mask. High concentration reservoir, or because it delivers a high percentage of oxygen, but it's for short-term use only. Ensure bag is filled with oxygen before even attaching to patient. Do not turn down oxygen flow below 10 liters whenever the patient is attached to NRBM mask. So most other patients, either nasal
sound has gone.
Please remember also patients tidal respiratory failure risk, the Venturi mask will come into play, which is going to give a fixed performance with increasing oxygen flow, does not increase the FiO2 in such patients even by inadvertently. It is very, very accurate, between 24 to 40%. So monitoring and titration of oxygen, always question whether oxygen is really required. One, if so, what is the target oxygen range? And whenever a patient is put on oxygen, we need to monitor oxygen continuously, if not feasible, very, very frequently. So we need to make sure that the oxygen target is properly reached. It's not. So use minimum air. Make sure that new patients refer them to a place where ABGs are available. And don't use non-pre-breathable mask with flow rates less than 10 liters and flow rate Venturi without changing that device. So the Venturi, the color coding and the oxygen flow should be always be matched. So we should not again stop high concentration oxygen in a hypercapnic patient without titrating down first. So this is the national audit which happened over the years in UK, which showed that with repeated auditing and education, the oxygen prescription improved dramatically. Hopefully in our settings too, it will improve very soon. So we have to make sure that we need to improve. So again, I'm reiterating as last time, does this patient really need oxygen? Is the oxygen prescribed on the drug chart? So it needs to be prescribed on the drug chart, and which is the device which is best for my patient, and what is the target range, and how this is being achieved. So the key learning points: oxygen is a drug. Don't give it except in emergency. Always consider CO2 retention, even if the patient is not COPD, and select the best delivery device. Frequent monitoring of SpO2 is required in all patients on oxygen. Titrate oxygen up or down to achieve a target. 94 to 98, 88 to 92, whichever target you have in mind. So avoid hyperoxemia, risk if hypercapnia and adverse cerebral coronary effects are possible. So wean down oxygen at the earliest opportunity once stable. Never leave high concentration oxygen for prolonged periods. Thank you. Open to questions.
Thank you. Thank you, Dr. Nandagopal. I think, am I audible? First thing.
Yes, sir. You are audible, sir.
Audible. Okay. Now, that was a nice treatise on oxygen therapy. So now we have learned that what is oxygen and how to be given. And main thing is that oxygen is a drug and it has to be treated as a drug. I think we will take the questions later, or we leave it as such. You want the questions now?
Sir, if the questions are there.
So is there any questions? I'm looking at the chat box, but I don't find any questions there. So I don't find any questions in the chat box. So I
Okay,
think,
sir,
tell me.
I'll be happy to take them at the end, sir, if possible. No, not a problem.
Okay, we will keep it at the end. Please keep your questions ready so that we will move on to the next topic. Now there is a request from Dr. Dr. Srikanth. He wants his topic to be discussed a little earlier. So please pardon me, Dr. Prabhuram. And Dr. Venugopal could not join because of certain urgent this thing. I don't know whether he has come in right now. If he has come in, can he raise? Let us know. I don't think so. So anyway, we will move on to the next topic. Prabhuram, please wait for your Disney on evolution. We will move to first management of asthma, current updates. Now, asthma is a disease which we have been seeing, everyone has been treating. It is a disease which is every day people treat. There are a lot of developments in asthma. There has been a lot of guidelines, lot of newer drugs have come. And I will request Dr. Srikanth to come in and please tell us about management of asthma, current updates. Dr. Srikanth, please. Dr. Srikanth is a consultant pulmonologist. He is a professor. He was a professor in earlier in PSG hospitals, and he has been a teacher, postgraduate as well as undergraduate teacher. He is one of the known researchers in the country in clinical research, and he heads the division of clinical research in Institute of Lung Care, Hindustan Hospital. And also he is a very popular consultant. I will welcome Dr. Srikanth. Yes, Dr. Srikanth, you are not audible. நடுவுல கொஞ்சம் cracks இருக்கு. Some voice crack was there at the last. No sound is coming. Srikanth.
Hello.
Stuck. Yes, hello.
Can you hear me now? Is
yeah,
it clear?
I'm hearing you. I am hearing you. Others should say. We'll go ahead.
Okay.
Continue with your talk.
So after that very nice and important topic on oxygen, I come to a very common problem which cuts across specialties. Asthma, I think, is like hypertension and diabetes. Everyone faces asthma in their practice, no matter what specialty you are in. So I shall try to give a broad overview of what is happening in the recent updates, and I'll also start with some basics so that we have an idea about the management of asthma. So at the outset, I would like to thank IMA for this opportunity, Dr. Senthil for taking the initiative and inviting me here. So I'll just start. Slide is not moving. Slides are not moving. 1 second.
Nandagopal.
1 second, guys.
What?
Yeah. So I think we will start with the definition of asthma. So in order to understand the management of any problem, understanding the definition is very important, so that will tell us why certain investigations are being done and why the management is tailored in a particular direction. So I will just go through this definition in some detail. Asthma is each word here is important, is a heterogeneous disease. So that's very important, because initially asthma was thought to be just one simple bronchospastic disorder way back when it was the initial part, I mean. Now we know that it is not homogeneous. There are several phenotypes of asthma which is being unraveled till now. It is a heterogeneous disease and it is characterized by chronic airway inflammation. That word chronic again is very, very important. So it is not a disease where you get repeated acute attacks. No, you only get acute exacerbations on a chronic problem. So it is a chronic problem. So we need to understand this word in order to convey it in the proper way to the patient, so that unless this is conveyed, the patients may not really understand why they need to take your medications, even when they are apparently or normal, or when they are asymptomatic. So the word chronic is important. And its classical symptoms are, respiratory symptoms would be wheeze, shortness of breath, chest tightness, cough. The classical symptoms of asthma. Very important point, that varies over time and intensity. Very unlikely in most of the asthmatics you will see that somebody has a symptom throughout the year. It will be varying in time and intensity. It may be more during nights and early mornings. It may be less during other time. And the last point is also very important, together with variable expiratory airflow limitation. So again, to just reiterate, it's a heterogeneous disease. It's a chronic airway disease, and inflammation is very, very important part. It is characterized by the symptoms shown here, varies over a period of time, and there is variable airway limitation. Now, how do you look at airway inflammation? By doing a lung function test. It could either be a spirometry, or we have something called a peak expiratory flow rate, PEF, which can be done by the patient at bedside. Now, moving forward, technology is improving so much that just a matter of time before we have the ability to do spirometry at home also. So, but in short, this variable expiratory airflow limitation is a key point of asthma. Now, diagnosis of asthma actually is very simple, right? Most of us would agree that most of the times a patient comes and says, sir, 20 varshama asthma irukku, and most probably is right, correct? Yeah, so diagnosis of asthma is not very complicated, but overdiagnosis and underdiagnosis are very, very common. Let me just tell you how. Overdiagnosis can occur because all wheezes are not asthma, which we have been learning from our UG days, and that phrase holds good even now. Cardiac asthma is there. There are so many other reasons. COPD also can cause wheeze. There can be pulmonary eosinophilias, vasculitis, so on and so forth. I will not go into the detail, but remember that all wheeze is not asthma. Then underdiagnosis of asthma, again, completely in contrast, underdiagnosis happens because when asthma presents as a classical symptom, of cough, breathlessness, wheeze, there is no doubt in the diagnosis. But many a time, asthma will present only as a cough. This is a very, very common scenario in your clinical practice. So any person who comes with an undiagnosed cough, remember that one common etiology could be asthma. And studies have shown that many a time when they present as cough, which is called cough variant asthma, the diagnosis is often missed. So there we have this underdiagnosis, and unless the diagnosis is picked up, it is unlikely that the patient's cough will improve. So respiratory symptoms, as I said, can be sometimes non-specific. We all know diseases do not follow the textbook pattern. So multiple differential diagnoses of dyspnea and cough can be thought of. And access to spirometry globally is not very adequate or still to the acceptable level. So unlike other investigations, the access to spirometry, especially a good spirometry technique, is very, very important. As I said, peak flow meter is a very simple test, bedside test, which can be done and easily available, but it has its limitations. It cannot be compared to a complete total spirometry, but it does help in especially in picking up worsening of asthma. One can prescribe peak expiratory flow to the patients. Now again, this is a very crowded slide. Just make it very simple. So as soon as you suspect a patient who has come with a suspected asthma, what you do is you have a history, and a history I think is very, very important. 90% of the diagnosis of asthma or suspicion of asthma comes from history. So once you get a proper history, and if he's most of the times he could be a known asthmatic, you have to check whether the patient is already on inhaled corticosteroid treatment. We'll go to the treatment part a little later. So this slide, the idea is only to reiterate the fact that you have to take a proper history, a good examination, find out in the history, you need to know what the medications he's on, and whether the person has performed the lung function test, spirometry, or whether PEF readings available. And if so, you look at it, as I said, whether there is any variable link. So that will confirm that this patient has asthma. So we will go into the treatment details little later. So I will not spend much time here. So untreated bronchodilator response. Now, this word is very important. See, in respiratory system, there's a unique factor that we always look at the response after bronchodilator. So it is not that you do a spirometry and straight away diagnose asthma. Say, for example, you can take a blood pressure and say that this is high, hypertension is there, the value of HbA1c is so much, there is diabetes. But asthma is slightly different, where you have to do a double test. What we normally do is you do a spirometry, and if the FEV1, forced expiratory volume 1, is less than 80%, it's called obstructive pattern. Then you give a bronchodilator, usually a salbutamol, and then repeat. When you repeat the bronchodilator, you will see that the FEV1 goes. That is called bronchodilator response. Now that is very, very pathognomonic of bronchial asthma. And world over, globally, all the guidelines, including all the research protocols, accept that a bronchodilator response of 12% or more, which we call it reversible obstructive airway disease. Now that is the point which you need to remember. Obstructive airway disease, which is reversible, comes under asthma. Which is not reversible, we consider as COPD in a very broad term. So bronchodilator response, something we test. So as I said, the current guidelines are more than 12%, and 200 ml of increase is considered to be a diagnostic criteria. And without that, one can never be sure that dealing with asthma. Of course, there are variations. Sometimes you may not have. That is, again, they are all outliers. So I will not go into the new criteria. I think it is important for you to remember this important 12% value. Why is asthma important? Yes, it's like diabetes, hypertension, any other chronic problem. It's a huge burden to the patient, families, health system, and economy. The number of days of work loss, number of days children miss school due to asthma is still very high, and that needs to be kept in mind. Now, asthma mortality has considerably reduced today. Today, death due to asthma can be almost very rare. And in fact, any death due to asthma is a be questionable. One will probably go for an audit. It could be put in a mortality meeting. So because generally, if somebody dies of asthma, we always say, how come? Why did it happen? It should not happen. And one would like to see whether there are some other factors. So the point is, asthma mortality is still there. However, because of several reasons, which I shall come to, cumulative risk effects of oral now systemic corticosteroids usage in asthma has come down considerably, but still there are large areas where we need to improve, and the side effects of corticosteroids need to be kept in mind. We know that even a few courses of corticosteroids given orally can be harmful. To summarize, asthma morbidity and mortality are largely preventable. Especially today, mortality due to asthma is probably unacceptable. So when you treat asthma, as I told you, it is a chronic disorder. It is not that you just give a relief for the time being and send the patient home. It's like diabetes again, if I can quote. It's a long-term plan you need to have. So once you diagnose an asthmatic, your plan should be that, what am I going to give him a good quality of life? How am I going to ensure that he has a good sleep? Because nocturnal symptoms are very common. How do I ensure that this person is going to have a good lung function for the rest of his life? How do I ensure that he's able to be physically active? Today, many asthmatics are active sportsmen. They have been participating in national levels, and there are asthmatics who have won medals in the Olympics. So physical activity, any kind of sports is not going to be restricted because of asthma. Long-term asthma risk manifestation may include no exacerbation. Ideally, you should never have an exacerbation, and there should be a normal, stable, near normal, at least lung function is possible. And ideally, I would be very happy if my patients never read a maintenance oral steroids. One can always have exacerbations and get bursts of oral corticosteroids can be good for 5 to 7 days as a short burst, but nobody should be on a regular steroid. And we would also like to formulate a therapy where medication side effects are nil or very minimal, which again is thankfully possible with today's medications. Now, one also has to understand that patients sometimes in a very, very stable asthmatic doing extremely well may suddenly have a sudden worsening, and sometimes it can be fatal. That could be because of sudden triggers by any viruses or allergen or pollution. So if a patient is allergic to any particular thing, one needs to keep it in mind to avoid such provocative factors. And there is something called difficult to treat or severe asthma, which we will come to it a little later, and that's where probably a expert advice would be needed. So today we talk about assessing a patient, adjusting the therapy strategies, and review. So all the three are very important. So initially the assessment part is very important. And today, I think most of us would see that any middle-aged patient always has so many other comorbidities, diabetes, GRD, cardiac problems. So all these things kept in mind. And why this is important is the drug interactions. So the patient could be on a cardiac drug, which could cause cough, which could cause bronchospasm, or maybe the patient has such a significant GRD, which itself is the cause of, a cough and a wheeze, been confused with asthma. So you need to keep all these things in mind before you formulate your plan. And side effects, as I told, we'll come to it later. Most common side effect of inhaled corticosteroids are only oral candidiasis, which is completely preventable by rinsing the mouth or using a spacer, especially in pediatric patients. So very, very uncommon complication of oral candidiasis to be careful. It is not something to be bothered about, but one needs to remember that you have to use the inhaler appropriately, space the device if needed, and always rinse your mouth thoroughly and gargle and spit it out. That's very important. In fact, this has to be trained and retrained every time a patient comes. In fact, one of the dictum in asthma management is every patient who comes for a follow-up, you need to keep on educating the patient, which is going to be a constant endeavor for all of us. And as I said, parent caregiver satisfaction. In the case of a pediatric patient or even adult patient or elderly patient, the caregiver also needs to be educated. And most of the time, lack of educating the caregiver or the bystander can lead to failure of therapy, and exacerbations are possible because of that. And frequent or regular lung function also needs to be done to monitor the patient. Now, this is the GINA guidelines. Again, I will not go in too much of detail into this. Some concepts alone I think are very important. So before I go into this, you can see there are track 1 and track 2. Now, GINA is the body which has given us guidelines for the management of asthma globally, and by and large, all of us follow GINA guidelines. So initially there was only one option, track 1, track 2. Now there is something called track 1 and track 2. So the first track is the preferred one, the second is the alternate one. Now, the concept or the science behind this is, whenever you treat asthma, as I told you, it is an inflammatory disorder. So it is not merely a bronchospastic disorder. So if you only do a bronchodilator, the inflammation is going to build up over a period of time and the patient will become sick. It's like, giving a patient just paracetamol without treating the underlying cause with an antibiotic. So just a crude comparison. So best anti-inflammatory obviously is steroids. And since systemic steroids are known to cause side effects, inhaled steroids came into vogue, and inhaled steroids have totally revolutionized the management of asthma, have improved the quality of life in most of the patients, and has reduced the morbidity and mortality to very huge levels. In fact, inhaled corticosteroids can be compared one among the top interventions in the field of medicine, which has made a big change in the quality of life of an asthmatic. It goes without saying. So we can classify asthma treatment into two broad headings. One is the preventer treatment. Other is the reliever treatment. As the name suggests, one is prophylactic, preventing, other is to give relief medication. And we need to use the preventer or the prophylactic on a regular basis and the reliever medication on SOS basis. So the common errors which usually happen is patient keeps taking the reliever, that is the salbutamol inhaler, frequently because he gets relief, and fails to take the preventive inhaler, which is the inhaled corticosteroid. So among the inhaled corticosteroids, we have a number of options like beclomethasone, budesonide, fluticasone, mometasone. Ideally speaking, there is no steroid which is better than that, although there are a lot of theoretical points which I can say. I will not go into it. Any inhaled steroid which is available today is safe to use. The dosages would vary, which you can always refer. Now, inhaled corticosteroids will be given on a regular basis, either on a twice daily or a single once daily, depending upon the type of inhaled steroid. Most of them are twice daily, and your reliever needs to be used whenever the. Now, this was how it was for all these years. However, after a lot of other studies which are reviewed and newer information which has come up, now we have a slightly different strategy. Now, apart from inhaled corticosteroids and salbutamol, what are the other bronchodilators which are available in inhaled form are long-acting bronchodilators. So among them, you have the beta-2 agonist and anticholinergics. The beta-2 agonist would be salmeterol, formoterol, indacaterol, vilanterol. These are LABAs, we call it LABS, LABAs. Now, the anticholinergics come under the heading of LAMA, which is most common is tiotropium, and the newer one is the glycopyridine. Now, we are going to use these combinations in various ways to improve the patient symptoms. So, most common way would use is a combination of low-dose inhaled corticosteroids with the formoterol. Now, low-dose ICS could be, most commonly it is budesonide. Formoterol is the long. Now, formoterol is a long-acting bronchodilator with a unique action where it produces an immediate effect also. See, when you give salmeterol, it takes about 30 to 45 minutes for the patient to get the bronchodilator, which is sustained for 12 hours. In contrast, formoterol, as soon as you take, you get the bronchodilator within a few minutes, and which is sustained for 12 hours. So that is a very unique property of formoterol, which makes it possible to use this kind of therapy, which we call it MART therapy, maintenance and reliever therapy, MART. Now, what happens is step 1, step 2. Now, these steps are basically classified according to the severity of the asthma. So, step 1 is probably the patient has very mild symptoms, and step 5 has the maximum symptoms. So, in step 1 to step 2, all we need to do is in track 1 is use this low dose ICS formoterol, that is budesonide and formoterol combination, which is available as inhaler whenever you have a problem. Say, assume that the patient gets asthmatic attack once a week or twice a week or once in 2 weeks. He needs to use it only at that point of. Now, the advantage of this therapy is that formoterol is going to give a relief by bronchodilation, but at the same time, some amount of inhaled corticosteroid is pushed in. Now, this concept is a new concept, which the logic is that even though it's a very mild attack, giving a little bit of inhaled corticosteroids can prevent the future attacks, right? So in step 3, what we do is it's slightly more. So you'd go for a low dose maintenance ICS formoterol, wherein you give it on a maintenance dose. It is given. Again, if he has an asthma attack, you give this low dose ICS formoterol as an add-on. So again, you're not only giving a formoterol extra, but also pushing in more ICS. Now this therapy will again help to prevent future attacks. Moving on to step 4, the dosage of low dose becomes medium dose, the rest of the things become similar. So again, reiterate the concept is you start with an SOS ICS formoterol, move on to low dose maintenance and a medium dose maintenance. Current concept is we do not go for much for a high dose. Very rarely in step 5, sometimes you go for a high dose maintenance ICS formoterol, or we may add additional drugs like tiotropium, glycopyridine, and then there is a lot of new drugs which I will come to a little later, like the monoclonal antibodies and so many other experimental drugs are available in step 5. Let me tell you that most of the asthmatic patients would be well managed in step 1 to step 3. And again, when it says step 1, step 3 to step 5, it's not a permanent step. As and when the patients improve, they can always come down to, so it's a dynamic stage, they keep going up and down. So from step 5, once they stabilize, usually within 12 weeks or 3 months, they can always be brought down. So one needs to keep monitoring the patient and, keep advising the appropriate dose. Now, track 2 is the alternate one, which is the conventional type, where the patient is in regular inhaled corticosteroids and takes SABA. SABA is short-acting bronchodilator, that is salbutamol. So there you have low dose maintenance. Then you add LABA in the step 3. Then you go to medium or high dose maintenance. And again, step 5 is almost similar. Again, the difference is only this. You have a maintenance and reliever therapy in track 1, while you have a conventional maintenance therapy with an as needed reliever medication in track 2. Again, Gina keeps telling, assess the patient, adjust the therapies, review the patient. This is not, because what can happen is you start a therapy, sometimes the patient doesn't come back, there is no follow-up. The patient may continue to take some medications, or the patient may default. All these things have to be kept in mind. So this is again a repetition of a slide. I just thought to highlight it. I will just quickly go through it. What I told you, step 1 and step 2, step 3 and step 4, right? Step 5 is phenotypic investigation. Now, step 5 is a very complex session which would probably require expert advice and reference to an asthma clinic, where you need to find out. As I told you, it is a heterogeneous disease. There are some asthmatics who do not respond to therapy well. Now, just to give an example, that is based on the inflammation. We call it T2 inflammation high and T2 inflammation low. Now, again, what exactly it means is this particular type of asthmatics are resistant to therapy. So they may not actually show the improvement with inhaled corticosteroid as was seen in the previous group. So for this group is usually an obese individual. They are likely to be smokers, and they also have poor reversibility. As I told you in the first slide, bronchodilator responsiveness 12% may not be there. So this is a very special group which has attracted a lot of attention, and a lot of therapy is now being focused on this phenotypic patients. So add-on treatments, the step 5 I said LAMA, which is tiotropium and glycopyridine. And then we have a number of monoclonal antibodies. I know the names of MABs can be very confusing. Currently available in the market is omalizumab. Omalizumab basically targets IgG. Now, each MAB targets a particular interleukin or a particular receptor, and so one needs to use the MAB carefully in the right set of patients. In fact, as we move on, we would soon have a very, very clear phenotype of which patient which MAB. Omalizumab for anti-IgE. Similarly, the anti-IL5 is mepolizumab and benralizumab. And then you have dupilumab. Dupilumab is a more broad spectrum mab. You can say it acts against atopic, non-atopic, and different kinds of asthmatic. And tezepelumab is a new one which has been approved for severe asthma. And again, these are reserved for some very, very few patients. Of course, I didn't mention about montelukast. Yes, montelukast is also a prophylactic preventive therapy, which is quite effective in some patients, especially in children. Recently, there has been a black box warning of montelukast with neuropsychiatric problem. So just keep in mind again, this. Again, it is not so severe that one should not use it, but use it with caution, especially in history of psychiatric disorders. I would probably think twice before adding montelukast. So in 2019, this fundamental change in asthma management was done. Again, there will be a lot of repetition slides, which I will skip quickly. This is just to say that why do we need to give inhaled corticosteroids on SOS basis for mild asthma? Because for so many years, we were taught that for mild asthma, give only salbutamol, no need for SOS. Because of this data say that up to 27% of asthma death have been reported in patients with mild asthma. So because of this mortality, which is worrying, and exacerbations are highly unpredictable, and every exacerbation is a huge hit on the patient's lung function. So even 4 to 5 lifetime OCS courses can increase the adverse events of osteoporosis, diabetes, cataract. So these data have convinced Dina to say that, okay, and I think that's not the only reason, the safety of IC. We know that inhaled steroids are so safe, let's give an additional dose of IC even for mild patients. And it's not good to have a regular use of SABA. See, SABAs, they keep using this salbutamol. If you're going to use it regularly, it can cause increased hyperresponsiveness, can lead to repeated uses, can cause tachycardia, arrhythmias, and other things. And more than that, it is not going to address the basic problem of inflammation. So one should not be using. In fact, any patient who uses salbutamol very often means that asthma is not under control. So that is why as needed ICS and formoterol has now replaced the previous therapy and the preferred therapy of track 1. And this data also clearly showed that compared to as needed salbutamol, if you're going to use ICS for budesonide formoterol on an SOS basis, risk of severe exacerbations were reduced by 60% almost, which is very, very reassuring. And there's a lot of data which has come to it supporting this form of therapy. Yeah. So 32% reduction of this one was seen, 23% reduction with higher dose of ICS LABA was seen, and 17% reduction with the conventional best practice. So as you know that formoterol is such a good reliever medication, it also has a good combination with budesonide in producing an anti-inflammatory effect. And this has also been found to be effective in both asthmatics. We all know that all asthmatics do not have high eosinophilia. There is something called eosinophilic and non-eosinophilic asthma. And today, current therapy is being tailored towards 2 groups. Eosinophilic asthma, we have a specific group of monoclonal antibody, and non-eosinophilic asthma, which is the one which is going to be difficult to treat. So this therapy is now sort of been approved and standardized in most of the countries. And the other thing is, see, number of inhalers. I think that's also important. Many a times the patient gets confused. Say, for example, we used to give 2 inhalers. One, we usually tell the patient red inhaler. Red inhaler is the steroid inhaler. Blue inhaler is the salbutamol. So use your red regularly and blue when you want to. And so often it happens that the patient uses the blue regularly and red. In fact, very interesting feedbacks come. One of my patients told me that I asked him, why do you use that? He said, sir, சிவப்பு மருந்து விலை ஜாஸ்தி சார், அதான் பவரான மருந்து, அதனால தொந்தரவு வரும்போது அதை எடுக்கலாம். These kind of things do happen. So very, very important is training the patient. I think now that we have so many medications coming in, so many inhalers, for example, in hypertension, in coronary artery disease, we do combine 2 or 3 tablets in one. It makes things easy for everybody. Similarly, I think it's nice to have less number of inhalers. For example, I would like to have 2 or 3 drugs combined in one device so that I don't need to use multiple inhalers. So again, that's a huge advantage of budesonide formoterol, one single inhaler for maintenance and the same thing for reliever medication. Remember, all of you, that all asthma patients need to be educated about the warning signs. When I should contact the doctor, I should not keep on taking my reliever medication. So warning signs are very important. The frequency of salbutamol is increasing. Patient has recurrent nocturnal attacks. Patient becomes very breathless. And say most of us have a saturation at home. Oxygen saturation is dropping. It is time to go to the emergency. Of course, we have different types of inhalers, which I think would be a separate topic by itself. It could be MDI, it could be a dry powder. Not go into that now. The dosage is also given here. So budesonide, formoterol, beclomethasone, formoterol are two common things that are available. Budesonide, formoterol is widely used in our practice. So single inhaler comes in immediate dose form, can be used in DPI, and now we have different kinds of devices also coming into use. So high dose of inhaled steroids. Now that's again one important aspect I would like to touch upon. Today we do not go beyond medium doses of fillers. There was a time when we used to use high dose inhaled steroids for difficult patients. Today why we do not use is I have different options. It's like telling if I'm managing diabetes with drug A, I will not increase the dosage of drug A beyond a point. I would go for addition of drug B, because the concept is that when you have two drugs with a minimum dosage, they're less likely to cause side effects. Plus, there could be synergy. So again, that's the concept which is applied here. So beyond medium dose, I would just look forward to adding another drug like say tiotropium or something which are going up. So 800 micrograms of formoterol is something we commonly use. We do not go beyond that. So budesonide and remember that when you compare fluticasone and budesonide, fluticasone is half the dose of budesonide. So if you're using 800 micrograms of budesonide, you want to put to fluticasone, that is 8.5 is 400. 400 may not be available, so 500. It's available in 250. So roughly half the dose of fluticasone is what the conversion factor from budesonide. Very, very rarely we've seen patients requiring high dose of steroids today. Most of them, I said, would control. If not, we would go for additional drugs. Yeah, this is about the inhalers I told you. I'll just skip this. So how the patient can be managed in your practice would be the patient has daily symptoms, nocturnal awakenings, very often low lung function, recent exacerbation. I would go for a medium dose ICS formoterol budesonide formoterol, which would be maintenance and reliever. I will take it twice a daily and ask him to take if he has symptoms in between, and make a note of it when he comes and meets us to know that how often he is used. Of course, track do means the conventional method is you can use ICS LABA, salmeterol, fluticasone, budesonide, formoterol, anything as needed. SABA, that is salbutamol, glucosamine. Now remember that this MART, maintenance and reliever therapy, is applicable only for formoterol with ICS. You cannot use it for salmeterol because, as I told you, salmeterol does not have that immediate bronchodilator action, right? So only formoterol. So formoterol is available with budesonide and beclomethasone. So only these two combinations. Most of our data is available with budesonide. So practically, if you ask me, this therapy holds good only for budesonide formoterol therapy. Now symptoms are most days, wakes once a night, slightly better. You can use low dose maintenance and reliever therapy. And patient is fairly well, has very few symptoms, you can go for as needed. So just to simplify things, as needed, low dose, I would go for maintenance, medium dose maintenance, and most of our patients are quite happy with this therapy. So just to wind up the last few minutes, most important thing in asthma management, I would say, is confirming the diagnosis. I think any disease, especially asthma, because when the patient comes and you make a diagnosis of asthma, I think we need to understand that you're making a long-term, you're starting a long-term relationship with the patient. The patient will need to understand that this is not something that is likely to go away. Of course, childhood wheezing, many of them may go over the age of 12 or 14, but today I'm talking predominantly about adult asthma. Inhaler technique, poor incorrect inhaler technique is the most common cause of failure of therapy across the world. It is not complicated asthma. It is not resistant asthma. It is nothing of the T2 high and low I spoke about. Mostly it will be poor inhaler technique. Even I have seen an inhaler technique not being correct across educational strata. It doesn't. I don't think that educated people take better or anything else. It doesn't matter. We have to train them very well. And people who have been taking well also may start using it incorrectly over a period of time. So please recheck every time the patient comes to your clinic. And humans are known to default. It's a very, what do you say? Naturally, it comes to us, right? We will not take a medicine if you're feeling all right. I am all right, why should I take medicine? That holds good here also. So compliance is a huge problem. Comorbidities, many of them have associated up. Now, ENT is something which we need to always keep in mind. Can be a lot of overlapping can occur because it's a unified airway, as we all know. So kindly look into all areas of the ear, nose, throat, sinuses, polyps, postnasal drip, and whatnot. They all can cause, lead to treatment of asthma failure. Once you treat the ENT issue, your asthma improves. GRD, a very, very common problem. Of course, many drugs can cause GRD. Theophylline, which was so commonly used in asthma management before, now is very rarely used. can be one of the causes of GERD, but we know that GERD is a lifestyle disease, so many drugs can cause. So kindly look into all the medications which your patient is getting so as to find out if there is anything which is triggering the problem. So modify the risk factors at home. Today, I'm sure all of you will agree that post-COVID, I've just seen the number of pets are just going up enormously in every house. Almost everybody has a cat or a dog, love birds, whatnot. So kindly take a detailed history. Birds can lead to something called hypersensitive immunities. There's a different problem. So we need to keep in mind. Poor asthma control can also be related to pets at home. That also needs to be addressed. Medication side effects are not very high in inhalers, but inhaled corticosteroids, you rinse your mouth. LABAs sometimes are some people are very sensitive. They get palpitations and tremors. Anxiety, depression, and social difficulties. All said and done, asthma is a chronic disorder. It has its own stigma. So the patient could be depressed. There could be anxiety. Today patients are flooded with information from the from the social media, and they have so many options, and you don't know what they actually read, and probably could get into their own modes of treatment, which can cause a lot of problems. So educate. Asthma is a very, very important aspect. Consider non-pharmacological interactions. Do not forget that many of them could be smokers. Concealed smoking is very, very common, and smoking can be a major issue in poor control of asthma. And encourage them for vaccinations like influenza vaccine and pneumococcal vaccine is also given for these patients. Treating the comorbidities is very important. Now, before you go consider non-biological add-on therapy, I would think of many of the MABs in the future are going to make a huge difference. So just a few words about monoclonal antibodies. As I said, we already have mepolizumab, we have omalizumab and benralizumab available in the market. But moving forward, we could have a scenario where the asthma phenotype could be completely unraveled, and tomorrow we may see a particular patient say would be benefiting with particular drug. This particular patient may get side effect. You can probably predict to that extent what we call precision medicine or personalized medicine. That time is not very far off where we will be able to tailor-made therapies are possible for each patient, and that I think would be the future of asthma. I think I've almost come to the last. Stepping down, as I told you, is very, very important. In asthma, once the patient is doing well, always keep in mind that you have to come down. This is just the dosage of needle steroids. I think you can refer. I will not go into it too much. Remission of asthma. Yeah, very fastly asthma gets cured. I mean, that's a very, very difficult thing to say. Asthma can be fully under control. Many asthmatics sometimes claim cure, that maybe all B's is not asthma. That could be a non-asthmatic which has gone away. Of course, pediatric group we see 80% of them could outgrow, but generally asthma always needs monitoring, and you could have long periods of remission, and there could be exacerbation coming. So I think just a word about FeNO. We all are familiar about lung function. There is something called FeNO. FeNO is basically measuring the exhaled nitric oxide. To summarize what it is, it basically detects the inflammation in the airways, upper airways. So very, very useful test to monitor response to therapy. Somebody is on inhaled steroids, the FeNO will come down. So it helps me to find out whether the patient is compliant, adherent to therapy, and quite an excellent research tool. In all the research studies which we do, FeNO is used as a monitor once the patient is in the trial to know whether he is responding to therapy or not. So that is one thing which I thought of. And then again, allergen immunotherapy is a topic by itself. So again, for a lot of time, I'm not going into it. So maybe we can have one talk with Dr. Nagaraj, who's an expert in this area. So immunotherapy does benefit a selected group of patients, and there are some doctors globally who vouch by this and have claimed good results. I personally do not have much experience on this. Cough variant asthma, which I told you, is again, remember that cough alone could be a variant of symptom of asthma. Montelukast, I told you, very, very safe drug. There has been recent data which shows potential neuropsychiatric effects. Again, it's not very high, and FDA has not given any significant recall or anything, but one just needs to keep it in mind. Pulmonary rehabilitation, again, Dr. Umithan is a pioneer in this, so maybe he can share his views. Could play major role in COPD, asthma, ILDs, and all the respiratory disorders, something which again awareness is led, and patients need to make the best use of this also. Last but not the least, salbutamol tablet syrup oral theophylline still available, but we do not use it. We hardly use this in our regular practice. Very occasionally in pediatrics, sometimes oral syrups are used, but by and large, bronchodilator, if anybody is regularly, one should go for inhaled therapy rather than this one. Home nebulization, extremely popular today is nebulizer, and a lot of patients do think that I have got a nebulizer at home. I mean, it has become more of a cult kind of thing, you know. So nebulization, please remember that is not something which most of our asthmatics would ever need on a regular basis at home. Nebulizer is used only, you know, when you cannot use an inhaler. In fact, there is clear data to show that use of inhaler with a spacer is superior to nebulizer as long as delivery of steroids is concerned. So I would say that most of our patients are very well managed by inhalers with or without spacers, and nebulizers rarely needed. In some cases, we do need elderly people and somebody who is not able to use it. But remember that when you are using the nebulizer at home, you have to be very careful. There could be increased transmission of infection. Maintenance is very important. So I think I would probably use it only when it is extremely necessary. And of course, it's much more expensive to use than your conventional therapy. So these are all the various inhalers which are available. Okay, I think hands-on training on the inhalers is very, very important. You have the conventional metered-dose inhaler, you have the tripolar inhaler, and then you also have a lot of other today breath-actuated devices wherein you just breathe in, automatically you don't even have to press it. They are called breath-activated. So more and more new devices are coming for two reasons. One, ease of use is something which we wanted, and the delivery to the respiratory tract has to be efficient. So that would make it. But let me tell you, choice of inhaler is very, very important. And there is nothing called the best inhaler. Every patient will probably prefer a particular choice. I think it's best to give the choice to the patient. And before you prescribe an inhaler, make sure that the patient is comfortable with it and uses it appropriately. Finally, I wind up with this statement. This is our own data from India. 46% of global asthma deaths occur in India, which is very high. I think it's time to take asthma serious. This was a 2019 data from Dr. Sandeep Salvi, who's a pioneer in obstructive airway disease. I think once we all understand, the take-home message would be, it's an inflammatory disorder. We need to attack the inflammation. Inhaled corticosteroids are extremely safe to use with hardly any side effects. I'm sure that the morbidity and mortality can be brought down efficiently. Thank you very much for your hearing.
Thank you very much, Dr. Srikanth. That was a good explanation of the newer and the current concepts on asthma. And there are a few questions which have been addressed to you. Would you stay or should I answer for them? No. Should we take the questions now or after the talks?
I'm okay with anything. I can take.
Your voice is not very clear.
Fine with you.
We will take the questions later because we are in a hurry. We are short of time. There was some delay in these things. So
Sure.
I will go to the next topic, which will be we have for that 2 more topics have to be covered, and we have one Dr. Prabhuram from TMF Hospital, Tirupur. He's a young and upcoming pulmonologist, very much interested in obstructive airway disease and rehabilitation. He will talk on dyspnea for evaluation. How to evaluate a dyspnea. Dr. Prabhuram, can you join us, please? Dr. Prabhuram, is he there? And has Venugopal joined us? Dr. Venugopal, please respond if you have joined us.
Sir, Venu doesn't look like he has joined yet. Prabhuram is there.
He is speaking on mobile.
Prabhuram is the co-host, so he should be able to start screening the procedure. I mean, screening his screen share should be possible. So, but he has not yet joined. Sir, Unithan sir. Sir, Shrikant sir, are you online?
Yes, no, I'm online.
Sir, we are not able to hear you clearly. We can hear you speak, but we can't hear you clearly.
I am available.
So sir, I think yes, sir. I can.
Yes, I am available. I can
Yes,
hear
sir. Sir, the program is having some difficulty.
you. We can take questions.
No, the program is having some difficulty in joining. So,
Okay, done. Okay.
yeah, he's joined, sir. Yeah.
Sorry, sir.
So we thought we'll go through the questions. Okay, since you joined back, I think I will leave to you.
Yeah, okay.
And Unithan sir, ennachu? Unithan sir
asked me to. I am being muted.
Oh, sir, I'll do that.
Sir, is my screen visible, sir?
Just 1 minute.
Yeah.
Yeah.
Yeah, your skin is visible now.
Fine, sir. Okay.
Yeah.
Yeah, everything is in order now.
So, shall I start, sir?
Yeah, please go ahead.
Yeah.
Start.
Okay.
Start.
Thank you. So, at the outset, I'd like to thank Dr. Sendil Kumar of IMA CGP, Jaimon Unithan sir, Nandagopal sir, Shrikant sir. So, to talk after these stalwarts is a big challenge for me. So, I'll try my level best to give as much information as possible for the GPs on the topic of dyspnea for evaluation. So, dyspnea for evaluation, actually, it is a very broad topic. I'm just going to give a bird's eye view on how the general practitioners should approach a patient coming to our OPD with dyspnea. Because a lot of the time, what happens when any patient with dyspnea comes to our OP, so we are generally confused as of what is the cause for dyspnea. Is it cardiac, is it pulmonary, or is it something else? So that is always a big puzzle to solve. So even for a pulmonologist like me, we have many cases of cardiac patients coming to our OPD, and even we are confused. We get help from our cardiology colleagues. So it happens very often. So if it is the case with us, then I can just imagine the plight of the general practitioners. It is quite a difficult topic. So what I'll do in my another 20-25 minutes is I'll just try to make it as simple as possible so that you'll get some idea on how to approach a patient coming to your OPD with dyspnea. So definition of breathlessness or dyspnea, it is a subjective experience of breathing discomfort that consists of qualitatively different sensations that vary in intensity. This is the ATS guidelines definition of dyspnea. So it is a subjective experience of breathing discomfort. So first we should know what is not breathlessness or dyspnea. So we should understand that dyspnea and the oxygen saturation of hemoglobin does not correlate. So if a patient comes with dyspnea and if you put the pulse oximeter, if the saturation is 99 or 100%, so it is not we should not take it for granted that patient, it is not dyspnea. So we see so many patients with normal saturation, but patients are dyspneic. So there is no direct correlation between saturation and dyspnea. Similarly, if you do an ABG and the PA2 is normal, it doesn't mean that the patient is not dyspneic. So saturation and the PA.
Did you get logged out in between, sir? Did you get logged out in between?
Yeah.
So probably that's why when we come in, it will be automatically loaded.
No, you are on.
So should I continue, sir? Yeah. So pathophysiology of dyspnea, I'm not going to go into the detail of the pathophysiology. I'll just touch upon a very basic thing. So what happens in dyspnea is there is a mismatch between the afferent and efferent signaling. So afferent signaling comes from the various receptors which are present in the lung, chest wall, and the signal goes to the brain, and the efferent signals comes from the brain to these organs. So if there is a mismatch between the afferent and efferent signaling, then basically a patient feels dyspneic. So any patient with breathlessness should be ideally referred to a concerned specialist. So that is our main job. So, but before referring a patient to a concerned specialist, we should evaluate the patient as to find out to whom we should refer, and the initial management of first aid should definitely be done by general practitioners. So the question comes is, which specialist should we refer? A cardiologist or pulmonologist? Basically, these are the two specialties, and there are other causes also, but basically it will be the tussle between a cardiologist or a pulmonologist. And what is the initial management that we can do? So this is the main focus of my presentation. So the common causes of breathlessness, pulmonary, cardiac, and others. Pulmonary, the most commonest things are asthma and COPD. Apart from that, there is pneumonia, pleural effusion, pneumothorax, ILD, pulmonary embolism, and OSA, which is obstructive sleep apnea, and chest wall deformity can also cause dyspnea. Cardiac causes is commonly acute coronary syndrome, acute myocardial infarction, congestive cardiac failure, pericardial effusion or tamponade, arrhythmias, pericarditis, valvular heart disease. These are the common cardiac causes of dyspnea. And others, anemia, ascites, anxiety. So anxiety or the somatic hyperventilation is very common. We see in our day-to-day practice. And acidosis, CVA patients who aspirate can become dyspneic, or those with recurrent laryngeal palsy. And iatrogenic is also quite common due to fluid overload status. When we give IV fluids very fastly in patients with underlying cardiac disease, then iatrogenic dyspnea is also a possibility. So as a general practitioner, how should I evaluate breathlessness? This is the main crux of my topic. So first, we'll be assessing the symptoms. We'll ask the symptoms of the patient. So when did it start, whether it's acute, subacute, or chronic? And what is the position in which breathlessness is aggravated? What is the timing of the breathlessness? What are the associated symptoms? And then we'll go to the physical examination, and finally we'll do the investigations. And we'll come to a conclusion whether it's cardiac or pulmonary or others. So coming to the onset and course, which is acute causes, usually within minutes. So respiratory, as you all know, it is acute exacerbation of asthma, a pneumothorax, a pulmonary embolism. If it is a pediatric, then the first thing should come to mind is a foreign body, a laryngeal edema. And cardiac causes includes acute myocardial infarction, congestive heart failure, pericardial tamponade, aortic dissection. So these are the various causes in which the dyspnea happens in a very acute fashion within minutes. The subacute causes are can be within hours, within days, or within weeks. Usually within hours and within days is interchangeable. It can happen within hours and within days also, like left heart failure, pneumonia, asthma, ARDS. Within weeks, usually pleural effusion, it usually takes time to settle in and the fluid accumulate. Anemia also takes some time. And muscle weakness and tumors, it will also take some time. Chronic causes are COPD, chronic bronchial asthma, chronic bronchitis, an empyema, pleural effusion, pleural malignancy, ILDs, and the vascular causes like AV malformation. It usually takes a chronic course. Then coming to the position of breathlessness, there is patient is having orthopnea, that is the dyspnea is more on lying flat. So the main differential diagnosis is congestive heart failure, left ventricular failure, some cases of COPD, asthma, massive pleural effusion. They can also have orthopnea. The opposite of orthopnea is the platypnea, where the patient gets relieved of breathlessness in lying down position. That happens in left atrial myxoma, massive pulmonary embolism, intercostal muscle paralysis. These are the very common causes of platypnea. And trepopnea is when the patient feels breathless on lying down on a particular side. This is very common in diseases of one lung like pleural effusion or a mass, and also in congestive cardiac failure. So based on these positions, we can just identify what might be the cause. So then timing of breathlessness, usually nocturnal onset dyspnea is very common in congestive cardiac failure, COPD, bronchial asthma. Underlying heart failure also, mostly the dyspnea is more in the night. And postprandial dyspnea can happen in GERD, aspiration, or some food allergy. And we can also ask associated symptoms like chest pain, wheeze, fever, change in the pitch of the voice, whether the patient is having hemoptysis, heartburns. So all these questions will give us some idea on which system is involved, and how to go about it. And the most important thing is when a patient comes to you, we should know whether it is an urgent problem which needs our immediate attention. So patient coming with dyspnea comes to OP, first thing we should assess is the patient going to live long enough to give you a history. So if not, we have to intervene. If there is a chance, then we have to ask the questions, which I already said, and do some basic investigations, and we try to make a reasonable diagnosis. So what are the red flag warnings? So these are the red flag warnings. So a patient comes with any of these red flag warnings, we should be very alert. So we should be very quick in doing the initial assessment and initial treatment, and then refer to a concerned specialist. So the patient is having tachypnea, where the respiratory rate is more than 24 or apneic, then it is a red flag alert. Patient is gasping for breath without movement of air, it is a red flag alert. Then if there is excessive use of the accessory muscle of respiration, patient is having hypotension, hypoxemia, so unilateral, there is absent of breath sounds or altered consciousness. These are all the various red flags where we have to be very careful in seeing these patients. So how to suspect? So the basic idea is, as a general practitioner, you don't have to know all the diagnosis. But as I already said, we have to evaluate whether there is a threat to life, and we should know when to intervene, how to intervene, and what are the tools that we have in our hand, and what are the interventions that we can do, and know when to get help. So these are the basic aspects that as a general practitioner that we should do. So suppose if there is any mechanical airway obstruction, the airway obstruction can be external. We should see for any gag or strangulation or smothering. So internal obstruction in the airway can be a food bolus or any peanuts or any beads or breads or anything. There could be any growth or a tumor or abscess. So there could be pus, blood inside the airway. So these are the causes which can cause mechanical obstruction. So then we should see whether there is any muscular or chest wall system involvement, like chest wall muscles, accessory muscles, myasthenia, or if there is any increased muscle tension that we have to assess. And then once the air goes into the lung and it has to, there should be gas exchange. We should find whether there is any problem with the air to blood interface, whether the alveoli is filled with some blood or mucus or secretions, whether there is some problem in the interstitium, or whether if there is anemia and there is not enough blood flowing through it. So these are the things which can cause dyspnea. So once from the symptoms, we can get a reasonable assessment of where the problem is, which reason of the problem, and we just try to correct it with our available tools. So the treatment part, I think it is a very huge thing, which I'm not going to say in this lecture. It is the topic for another detailed lecture, so which we might discuss it some other day. So, now we have seen a patient who's coming with dyspnea. We have assessed. We found whether the patient is very sick or he's reasonably stable. When asking the questions about the periodicity and the onset, we come to a reasonable clinical conclusion. Then we can do some easily performed initial investigations. An ECG, I think most of us have in our clinic, an X-ray, and screening spirometry. So spirometry, I'll just touch upon the spirometry in a few slides, which I'll be presenting later. CT chest and echo optional, not everybody might have, but now I think with the mushrooming of so many CT centers, I think many of us general practitioners, we do CT as an initial investigation rather than X-ray chest also. That also happens. So these are the easily performed initial investigations. So now what I'll do is I'll put the abnormal reports, and then I'll just explain how to go about it, how to diagnose. So ECG scribbles the answers, though not always. So we should practice. So just imagine a chemist reading a doctor's prescription, how difficult it will be for them. So same way, if you don't know about the ECG, if you look at the ECG, then it'll look like Greek and Latin. But if you have a systematic approach, it usually we can find out the critical illness. It is not possible for a general practitioner to identify all the things in ECG, but at least some basic things if we identify, it will be useful in treating the patient. So first ECG is an acute MI, as we can clearly see that there is an ST elevation in leads V1 to V6. It is an anterolateral, acute anterolateral MI. So it is a classical case. So what we can do is immediately we can give the Statrix and refer to a cardiologist. This is a complete hot block. Monomorphic VT, where we can see wide QRS complexes of uniform morphology. Polymorphic VT, wide QRS, but the morphology is different. So these are the various commonest things which we can pick up in ECG. Coming to chest X-ray, chest X-ray as such, it is insufficient by itself. Just by seeing the X-ray, we cannot diagnose anything. So by taking a clear-cut history, by examination, along with that, if we see the X-ray, then we can come to a reasonable diagnosis. So my basic suggestion to all of you is we should read our own X-rays. We should not depend on the report by a radiologist, because we have found out that sometimes there may be a discrepancy, because the radiologist just gets to see only the X-ray, but we see the patient. So we will be in a better position to read the chest X-ray. So the most commonest things which we have to look in a chest X-rays, look for pneumothorax, aortic dissection, pneumonia, effusions, and collapse or atelectasis, and pulmonary infiltrates. These are the common things which we can see in an X-ray. So next few slides, I'll be putting the X-ray which I have seen in my day-to-day practice and just explain to you. This is cardiomegaly. So you all know how cardiomegaly will look. So if a patient presents with this sort of X-ray, then mostly it points towards a cardiac etiology, and we have to refer to a cardiologist basically. So pulmonary edema is another very common thing. A patient comes to you with acute onset of breathlessness, and we can see, you can hear the audible creps outside. You see the blood pressure is very high, like 200, 210, or sometimes it can be hypotension also. Patient with acute myocardial infarction, very massive one, can present with shock also, and can present with pulmonary edema. So pulmonary edema is there, then mostly it goes towards a cardiac etiology, but rarely it could be a pulmonary etiology also, but mostly it goes to a cardiac etiology, where you can see basal infiltrates in the bilateral lung fields. And this is the pneumothorax. Patient presenting with acute onset breathlessness, you can see the left side there is pneumothorax, and there is a collapsed lung, and around the collapsed lung we can see a pneumothorax where the lung markings are almost absent. You can see there is a mild tracheal shift to the right also. So this is a case of pneumothorax. And this is a lobar pneumonia, where you can see the fissure, and there is accumulation of secretion below the fissure. It is a lower lobe collapse, or lower lobe pneumonia actually. So this is a bulging fissure in klebsiella pneumonia, where you can see the fissure is bulging down. So patient usually presents with high-grade fever, tachypnea, sometimes hypoxia also, with purulent secretions. Then we have to think about pneumonia. And this is a patient of pleural effusion, where you can see there is a homogeneous opacity in the right lower lobe. Postophrenic angle is blunted. So this is a case of right-sided pleural effusion. And this is a case of IPF. The patient is an elderly patient who is a smoker, who is having a breathlessness of chronic duration, gradually progressing. And when you auscultate, you get inspiratory creps in the basal area, and X-ray something like this, then it can be IPF, which has to be confirmed by a CT. And this is a squamous cell carcinoma actually. So initially you can see air fluid level surrounded by consolidation. Then you can see the next X-ray, you can see how the lung itself is getting collapsed. So this is a squamous cell carcinoma. And some rather rarer causes is rheumatoid pneumonia. It is not very common, but we could see some cases of rheumatoid pneumonia also, where patients will give the clear-cut history of multiple joint pains, and then you evaluate this rheumatoid arthritis. Then during the course of the illness, they can get a rheumatoid pneumonia. And bronchoalveolar carcinoma, it just looks like pneumonia, but it is a carcinoma. And in this, you can see a well-defined round soft tissue mass overlaying the right hilum. So it is actually a malignant growth. It's a bronchial carcinoid. And this you can see there is a right upper lobe mass with extensive right paratracheal and hilar lymphadenopathy. So this is a case of small cell carcinoma. And similarly, here also you can see bilateral hilar adenopathy, right side pleural effusion, along with some collapse also. This is actually a Hodgkin's disease. And these are multiple well-defined rounded opacities due to adenocarcinoma of unknown primary. This is actually a pulmonary metastasis, which we commonly say as a cannonball appearance. And this is a case of miliary TB. So patient is a young adult, emaciated, a chronic fever, weight loss, looking cachexic, and if an X-ray is showing miliary nodules, then there is a high probability of being a miliary tuberculosis. And these are tubercular cavities, which we all see in a day-to-day patients. So they'll have a good tubercular history, chronic sputum production, evening rise of temperature, weight loss. And here you can see in the right upper lobe, there is a huge cavity. These are also tubercular cavities, multiple cavities in both the bilateral upper lobes. So these patients also become dyspneic. These are rare cases of silicosis, where we get patients with progressive dyspnea, and they usually have an exposure to sand, mud, or rock exposure. So this is also silicosis, where there are multiple densities in both the upper lobes, and this is axial calcification, which we see in silicosis. And this is a case of left side pleural effusion with asbestosis, where we can see the pleural thickening, which is very characteristic of asbestosis. So I just gave a glimpse of what are the things which we can see on taking an X-ray chest of a patient who is having dyspnea. So by seeing this, we can come to a reasonable conclusion. And if these changes are there in the X-ray, then we can confidently refer the patient to a pulmonologist after doing our initial management, whatever is possible. But unfortunately, in many of the common cases like asthma, there is no change which could be found out by seeing an X-ray. So we have to rely on spirometry. Spirometry is one of the underused investigations. It's very simple to use. The machine is also not very costly. It is very cheaper than an ECG machine also. Nowadays, 20,000-30,000, we can easily get a spirometry. So when you add a spirometry with an X-ray, then the diagnosis becomes even more easier. So this is a patient of bronchial asthma, where you can see the X-ray is almost normal, except for some hyperinflation. But the spirometry can clearly see there is an concavity in the expiratory loop, which is the classical of bronchial asthma. This is COPD. COPD, we can diagnose somewhat in X-ray and the clinical, but still the gold standard investigation of choice is spirometry, where we can see there is a reduction in FEV1, FVC, and FEV1 by FVC. So these are the simple things which we can find out by doing a spirometry. This is a restrictive lung disease, a patient of restrictive lung disease, where spirometry will also give some idea about the restrictive lung disease. So X-ray, ECG, and spirometry solves almost 90% of the dilemma. And CT scan, as of now, as I already said, more and more CTs are being done. So CT scan findings also can help us to diagnose patient of dyspnea. This is a case of bronchopneumonia, where you can see multiple infiltrates. This is a classical air bronchogram, where you can see the patent bronchi being surrounded by the consolidation. This is peribronchial consolidation, where there is consolidation surrounding the bronchus. And this is pneumocystis jirovecii pneumonia, which is common in patients with HIV. And here you can see idiopathic pulmonary fibrosis, where there is honeycombing, subpleural honeycombing, and interstitial thickening. This is classical honeycombing, which is seen in idiopathic pulmonary fibrosis, usually peripheral and subpleural. And this is lymphangioliomatosis, where we can see a lot of cystic swellings in both the bilateral lung areas. And this is primary Langerhans cell cystocytosis. And this is Sjogren's syndrome, where you can see multiple cystic lesions in the lung. And another important thing which I want to emphasize is a case of pulmonary embolism. So actually, this patient was a middle-aged female who came to me with symptoms of breathlessness for the past 2 days. So when I examined the patient, when I asked the history, there was not the suspicious history. Then I ausculted the patient. The lung sounds were normal. Bilateral lung entry is air entry is normal. Saturation was 99%. Heart rate was around 100. So then usually we think in female middle-aged with no obvious clinical signs. So it could be psychological. So I was just pestering her about questions. Do you have any family problem, any stress, anxiety? And as usual, she gave some clue. So now about the X-ray was normal. So I was about to label it as psychological, but still I had some doubt. So what I did is I asked the patient to walk in my corridor for a few minutes. So this practice actually we basically learned during our COVID times. So during COVID times, if patient waits in our OPD for a long time, comes inside, patient looks absolutely normal. So what we do is, ideally we should do a 6-minute walk test, but it takes a lot of time. So we just ask the patient to walk in the corridor. Sometimes client stares also. So if there is a significant desaturation or if there is a tachycardia, so then it gives a clue that there is some organic cause which is there inside. So I employed the same formula to this patient. I asked the patient to walk in my corridor for 2-3 minutes. And when she came back, she was so tachypneic and so dyspneic, and her saturation went to 92%. Then I thought, so there is something tricky inside. So ECG was normal. And before doing the echo, I did a CT pulmonary angio and I found an embolus, which could be seen clearly as a filling defect here. So before labeling a patient as psychological or anxiety, we should do a proper evaluation. But unfortunately, as a general practitioner, we won't be able to go up to this extent, but at least we could just ask the patient to walk for a few minutes in our outside our OPD. And if there is a significant desaturation, 3% to 5% desaturated from the baseline oxygen levels, or if there is a significant tachycardia and the patient is tachypneic after exertion, then definitely there is some underlying organic cause. And if we have an ECG, we could do it. And if X-ray is also normal, then we could send to a pulmonologist for further evaluation. So this is one point which I wanted to emphasize, because I have seen so many patients who have been going to GPs and for a few visits for a few days, and they are branded as anxiety induced. And when they come to us, we find out these diagnoses. And the problem with this is, if it is not treated initially within a few days, then it could be a chronic problem which could cause lifelong morbidity. So the earlier that we pick up, the better. So I think this you all can do in your OPD. So this is a thick-walled squamous cell carcinoma. The point which I wanted to stress is all cavities are not tubercular. So before any microbiological or pathological diagnosis, we can't label them as TB and start ITT. This is another common practice which happens. So it could be a malignancy also. So squamous cell carcinoma could present with cavities in the X-ray and CT. So this is another adenocarcinoma where we can see speculated margins in the ends of the tumor, which points towards malignancy. And this is an allergic bronchopulmonary aspergillosis. Patient with chronic asthma uncontrolled can be a case of ABPA. So that also we should diagnose. And this is an aspergilloma. So these are the various things which could be found in an CT. So we are done with X-ray, we are done with ECG, we are done with the combo of X-ray and spirometry, CT scan. And finally, I just touch upon echocardiogram. So echocardiogram is a video of heart with some color, and it is not just ejection fraction. So you should not just stick with it, because whenever an echo comes, we'll just see what is the EF. So it should not be EF alone. There are so many things that could be seen by an echo, like cardiac complaint, RB dysfunction, IBC size. If the IBC is not collapsible, then it could be a fluid overload status. So many things echo can give us an idea. So if possible, if we have a bedside echo, a portable echo, then we can just do it. So as a general practitioner level, I don't think it is a feasible thing. But in the future, just like a stethoscope, I think echo and this spirometry should be added in the paradigm of a general practitioner, because this gives so many clues in the diagnosis. So what are the tests we can do? We can do an ABG. ABG will give us an idea about whether it is a metabolic cause or respiratory cause. So causes like diabetic ketoacidosis and renal tubular acidosis that could be easily picked up by an ABG. And then ultrasound chest, it is also a valuable tool because we could pick up so many things with an ultrasound. And then the labs, BNP, and then cardiac enzymes, renal function tests, these all can give a differential diagnosis of breathlessness. So finally, last 2-3 slides, I'd like to touch upon my hardcore areas. One is obstructive sleep apnea. So obstructive sleep apnea is a very underdiagnosed problem, wherein patient can have choking episodes during sleep, where the patient gets an airway obstruction, and patient can become hypoxic during sleep. And due to that, they can be hypersomnolence during the daytime. It is very underdiagnosed entity. I'm not going into the detail. I just wanted to stress upon the point that OSA also should be considered in a patient having breathlessness. Patient having snoring or breathlessness during night, then definitely they should go for a overnight polysomnography. Here you can see there is a desaturation, and along with the desaturation, there is abnormal chest and abdomen movements. There is an increase in BP, and that EEG shows activity, and ECG is also abnormal. So that is an obstructive event. So patients with OSA, obviously they should go for a continuous positive airway pressure. It could be a CPAP or BiPAP, depending on the clinical condition of the patient. So this is my final slide. So I'm currently running this Kanaga Ramalingam Pulmonary Rehabilitation Center. So pulmonary rehabilitation, as Shrikant sir said, is an underutilized area. So now there is more awareness towards this, and here we have been doing this for the past 7-8 years. Patients of chronic asthma with airway remodeling, COPD, ILD, and so many cases come to a rehab center either as an OPD basis and also inpatient, and it is showing very good results. And in my experience, it is one of the most important modality which gives a qualitative improvement to the patient symptoms rather than all our other interventions in case of COPD asthma. So I think more and more of general practitioners should make use of this facility, and I could see a very good future for rehab with the opening of more such rehab centers, and I hope that patients get benefited by this. So in conclusion, life is like a puzzle. It all seems a mess, but when it gets fixed, it looks awesome. The same thing applies to solving the puzzle of breathlessness too. So initially, when a patient comes to us with the breathlessness, it is a very big puzzle to solve. So when we do the evaluation is in a very methodical way, from the clinical, first asking the symptoms, the onset of breathlessness, the position, the diurnal variation, then doing our clinical examination, finding the red flags, doing the basic investigations like ECG, chest X-ray, along with spirometry. Then we could have a reasonable conclusion on what is the diagnosis. And then as general practitioners, whatever initial management that we could do, that we can do only if we know the diagnosis. Because many times what happens, a patient of congestive cardiac failure, we nebulize the patient. And a patient of tuberculosis, we give intravenous steroids. So that sort of blunder we need not make. Once we get a fair idea of what will be the probable diagnosis, then initial management can be done properly. And proper referral to the concerned consultant could be done. As I already said in the first presentation, many patients of asthma go to the cardiologist, and many patients of heart failure comes to us. So it is actually a tussle between a pulmonologist and cardiologist. So if we have, and a lot of time gets wasted on these referrals also. So if we get a basic idea on how to go about it, I think it will be very beneficial for the patient. It is a tricky puzzle to solve, but once you go it in a methodical way, I think it could be solved easily. Thank you for your patient listening.
Thank you very much, Prabhuram, for overall evaluation of dyspnea. Hope it will be a very useful talk for many of us. And we will, there are some questions for you also. And we will wait for the question answers at the last. We'll take up the questions. Now, I will move on to, I think Venugopal is available. Venugopal, sir, please respond. Take off your slides from here, program.
Yes, sir. Yes, sir. I'll do so.
And yeah, now I will go on to Dr. Venugopal. Can I know if Venugopal is available? Venu, tell me. Hello? Hello? Yeah. Okay, okay, I will do that. Can somebody, Nandagopal? Are you available, Nandagopal? Can you, or Dr. Senthil, can you unmute Dr. Venugopal? One moment, please. Just hold on for a few moments. The program is getting unmuted. Talking about pleural effusion is an important topic because there are a lot of times we get confused with consultation and effusion. There are a lot of things that happens that pleural effusions always confuse. As I said earlier, all pleural effusions were treated as tubercular unless otherwise proved, but today the situation is not so. And we have here Dr. Venugopal, who is from KMCH, a leading interventional pulmonologist, and he will tell us something about clinical pulse in pleural effusion. Over to Venugopal, please. Dr. Venugopal? I think he's unmuted. I'm not getting any response from anyone.
Sir, he has to unmute himself, I think.
Okay, I will tell him over the phone.
He is put up and his share as.
Yeah. I now got it, sir. Yes, sir.
Yes.
Oh, you have unmuted yourself?
Yes, sir. Yes.
Okay. Thank you. Thank you, Venugopal.
Yes, sir.
Okay. You can, the screen is yours.
Yes, sir. Yes. Sir, I think it's visible, sir.
Yes, you are visible.
But it's like
you have to expand it.
Share. Wait a second. It's not. I don't know.
Thoracoscopy you are doing?
Yes, sir.
You can give slide first, sir.
Okay, sir. Good evening, all.
Why don't you make it full screen?
Yeah, that's not. I couldn't.
You are not able to.
Yeah.
Okay, go ahead with this.
Fine, sir. Yeah, sir. Good evening, everyone. Thanks for the organizing team for the invite. My sincere apologies that there was a misunderstanding from on the date, and so sorry for the inconvenience. And anyhow, I try to do justice for the next 20 minutes for the audience. So coming to the pleural effusion, it's an important entity we come across in clinical practice. Really, we have to differentiate between like whether it is really an abnormal fluid or a normal fluid, because unlike a pneumothorax, the presence of air indicates a pneumothorax, whereas you have a small amount of always like a fluid will be there in the pleura for a lubricating purpose. So the pleural effusion definition goes like it's an abnormal or excessive collection of fluid in the pleural space. So that's, I think, I clear. So this could be either it could be an exudate or it could be a transudate. So basically, the exudate is like some pathology is happening in the lungs. I mean, the lungs or in the pleural space. So the pleura is secreting the fluid. So you have to identify whether it is an exudate or a transudate. Transudate is basically all the volume overload conditions, which in further it causes whatever the fluid to reaccumulate in the pleural space. So ideally, you have to differentiate between either a transudate or exudate. That is the key here. So which is a transudate? I said transudate is nothing but ultrafiltration of serum across the pleural membranes. So this happens due to like conditions like heart failure or cirrhosis, or in case of renal failure. Wherever volume overload condition is there, you will get. Basically, it will be symmetrical and equal on both sides. So I said the list being like all the chronic cardiac problems, all the chronic kidney problems, and of course the liver problems will land up in this transitive pleural effusions. Exudate, either it could be an inflammatory process happening in the pleural space or a malignant process happening in the pleural space. So it needs always to be investigated. Suppose transitive effusion, we need not investigate further. We have to just treat the underlying cause. So the most common things were the exudative pleural effusions, pneumonia, malignancy, and tuberculosis were the three most commonest causes, which accounts for almost more than 75% of the causes of the exudative pleural effusion. So I can say that we should master the pneumonia, malignancy, and tuberculosis, how it presents in the clinical picture. It's worth to know these details so that we'll be able to diagnose this case early and do the appropriate management, and if required, we can send to the specialist. So as I said, the exudative causes being right from neoplastic to it could be infections. Sometimes, rarely, it could be due to pulmonary embolisms. Sometimes the subphrenic anything, irritation to the diaphragm under subphrenic region, anything, either it could be an abscess or it could be a pancreatic pancreatitis, it can even cause effusion. So subdiaphragmatic pathology, any abdominal pathology can also cause an effusion, so which should also be remembered. And the drug induced pleural effusion, these are something like this should be like always a diagnosis of exclusion. So rarely these days, like the drugs like the dasatinib and especially these are tend to cost more. The list goes on. So many drugs are there, but these can also cause drug-induced pleural effusions, and of course, hemothorax, anything like blunt or penetrating trauma to the chest wall, and chylothorax. Sometimes, many often we see that milky white fluid. I often think that it's a pus, but always not. Sometimes a chyle. Chyle also looks like a milky fluid that can happen in traumatic cases or in some cardiac surgeries. You'll get some this chylothorax as effusion. So the commonest, as I said, it being tuberculosis, parapneumonic, and malignant effusions. So always the presentation will be most of the time breathlessness, because your complaints on the chest wall will be decreased, and the mediastinum being shifted and the diaphragm function being affected. So the patient will be having dyspnea, and of course dry cough. Dry cough always gives a sign towards a pleural pathology, or it could be an interstitial pathology. So it presents with a dry cough, and the pain will be like usually first initially it will be pleuritic type of pain. But when the effusion, this is because the inflamed pleura rub against each other. Whereas when the effusion keep on accumulating, the pleuritic pain changes to a dull sort of pain. And of course, in tubercular effusion, you do have weight loss, constitutional symptoms, and also in malignancy, you have the weight loss. And if it is transit effusion, you have all the features of heart failure, like elevated GVP and pedal edema. All this can be there in the clinical findings you can get. So how to differentiate between whether it's exudate or transit is the key here. Simple point, when the protein is more than 3, you keep it as exudative fluid. So there are, like, you can basically people, Lights is the one who tends to given the criteria. He used the LDH and the pleural fluid and serum LDH ratio greater than 0.6, or pleural fluid to serum protein greater than 0.5. But in a practical scenario, I say that if a pleural fluid protein is more than 3, we can say that it is more likely an exudative fluid. The confusion comes only when the patient is on diuretic therapy. Sometimes the patient is on diuretic therapy. Sometimes the transitive sometimes, like what you should know now, especially on other, it will be difficult to differentiate between a transit and exudative effusion. So what we should do is, when the patient is on diuretic therapy, you should always go for the gradient. You should always get into the gradient. Serum to pleural fluid, the gradient, you should look into it. The gradient I can suggest is when it is more than serum to pleural fluid gradient less than 3.1 gram per deciliter. That means like it's an exudative fluid. So whenever the patient is on diuretic, you go for this gradient, or else like you take it as when the protein is more than 3, we can with reasonable confidence we can say that is an exudative effusion. So this once again repetition. So regarding malignant effusion, there are two terminologies which we used to say. Malignant effusion means when you demonstrate a malignant cell in the pleural space because it is directly due to the infiltration of malignant deposit in the pleural space, that is malignant effusion. Sometimes in the same malignant setting, the fluid can be not because of directly or because of malignancy. Sometimes because of anything like other than the direct pleural involvement, it could be like secondary to hypoalemia, or sometimes like a thoracic duct obstruction can causing chylothorax. Something like this type of effusion, we label this as a para-malignant effusion. So, of course, lung, breast, and lymphomas accounts for the 78% of the malignancies. So, lung is one of the commonest cause for the malignant effusion, and sometimes 6% of the malignant pleural effusions we will not able to, whatever the thorough investigation you do, we will not able to find the what exactly the etiology being. So just I will going to highlight about only the three important disease: tubercular effusion, parapneumonic effusion, and malignant effusion, and little bit about I will be just showing some of the videos. That's it. Tubercular effusion is the one commonly we see. It's the fluid itself. It will be straw colored, and it's an exudative fluid, and pleural glucose will be most of the times it will be less, and usually it is around 60 milligram per deciliter. And in first 2 weeks, most of the times it will be lymphocyte predominant effusion. But when you pick up the tuberculous pleurisy at the initial stage, acute pleurisy, it can be neutrophilic. So it is an exudative fluid with the lymphocytic predominant and low glucose. And ADA is an enzyme which you should always send for analysis in a pleural fluid analysis. It's nothing to do with, I will make it simple. The ADA is like wherever like you have a lymphocyte rich effusion, the ADA is going to be more. That's as simple as like that. So the ADA more than 70, he says that the tubercular effusion we can make a confident diagnosis. But when the ADA is less than 40, it will be very difficult to make a confident diagnosis of TB, especially in those cases, the thoracoscopy, guided pleural biopsy plays a major role. So I said, so ADA, I said like it's not like will be specific for a TB, because whichever the effusion where lymphocyte is high, you will be able to get the higher ADA values. And of course, in any pus, the ADA will be high. So sending a pus and claiming that ADA is 80 or 90 and starting on ATT is definitely not justifiable. So in empyema, ADA will be high. Rheumatoid arthritis, ADA will be high. Bronchiolitis carcinoma, brucellosis, Q fever, these are all lymphocyte mediated immune response. So all these things, the ADA is higher. So beware of this false positive in of ADA values, and don't jump into diagnosis of tuberculosis. And polymerase chain reaction. So this basically, yeah, TB gene expert, basically all this, it can pick as few as 10 mycobacteria, but the problem is like that, the tubercular effusion is not like a direct due to disease pathology. It's basically a hypersensitive reaction to tubercular bacilli. So the sensitive, you will not be able to pick up a tubercular bacilli not in all cases of tubercular pleural effusion. So the sensitivity can be as low as 20% in gene expert. So sending a gene expert and ruling out tuberculosis is not a great idea. So if it is positive, you can make a diagnosis, but if it is negative, it could be a tubercular pleural effusion. So I said, what is the cause for false positive? False positive, it can be DNA contamination in presence of non-viable organism. This most of the times this is actually less encountered one, but only thing is like false negative values being on the higher side when in with respect to tubercular pleural effusions. And previously the costs were high, but now the availability of more and more centers, and we could be able to get the testing within 1,500 rupees. Of course, when the things are not working well with our initial diagnostic modalities, we have no other option. We have to go for this pleural biopsy. But this is the older needles which we are trying to use. That's called the closed method. I'm not this being almost like outdated these days. And the recent one being like we will be using putting a scope into the pleural cavity and visualizing the pleural surface and getting a biopsy out of the abnormal regions. That's what we try to do it. And the paranemonic effusions, as I said, I'm just finishing up the tubercular and jumping to the other topic, paranemonic effusion. What is meant by paranemonic effusion? Paranemonic, you have a pneumonia followed by developing an effusion. So that is paranemonic. So this means like infection has been spread from the parenchyma to the pleural space. So this could be a simple or a complicated. What it means is simple means you have a pleural fluid, but there is not much of loculations or anything that can be easily drained with a needle. So that is a simple paranemonic effusion. Whereas complicated means when you have so much of septations or loculations, like the pleural cavity being like almost like a honeycomb like structure, or something like a nest, bird nest like structure. So a lot of septations and localization means that means like it's a complicated thing. Something you have to put a drain or intrapleural streptokinase or a thoracoscopy. You have to drain it completely to get rid of the infective foci. So that is called complicated paranemonic effusion. So we can pick up the paranemonic effusion at a simple exudative phase or at a fibropleural stage or organizing stage. When it goes to this organizing pleural stage, we have no other option other than involving a cardiothoracic surgeon for decortication. And in this case, a simple drain may work well. And in this case, fibropurulent stage, I think we have to involve the pulmonologist for thoracoscopy. So chylothorax, yeah, just a single slide. Chylothorax, I said like it can happen due to a trauma or a malignancy. The malignancy, the commonest cause being lymphoma. So the point here is, I just want to make you emphasis that yeah, if you see a chyle in a pleural effusion and the patient doesn't have a history of trauma, it is unless otherwise proved, you are dealing with a lymphoma in the especially some mediastinal adenopathy and intrathoracic adenopathy you are dealing with, and you have to rule out lymphoma in such cases. And the triglyceride level greater than 110 or a presence of chylomicron gives the diagnosis of chylothorax. You have to specifically order these investigations when you are suspecting a chylothorax. And so just these are the nutshell. You have seen the malignant effusion. I'll be elaborating you in the clinical cases. So just I'm just finishing this theoretical part with the what are the final investigations we will be sending in a pleural effusion. We'll be sending an X-ray and ultrasound thorax, and we will be going for a diagnostic pleural aspiration and CT chest, especially if required in malignant effusions, and a thoracoscopy for undiagnosed pleural effusions or in a complicated paranemonic effusions where you need to clear the adhesions and drain out the pus. So diagnostic pleurocentesis, see, almost like all suspected exudative pleural effusions, you have to do it. In a clear-cut transudative pleural effusions, you have a bilateral symmetrical effusion and you have a heart failure patients, no need to perform the tap. Whereas a unilateral effusion, fever, that means like you have to do it. So always all suspected exudative cases, you have to go for a diagnostic fluorocentesis. And only the contraindication being when you have a bleeding diastasis and when you have an increased creatinine level greater than 6, this can be or you have a localized skin infection at the site, then maybe a contraindication, or else there will not be any major contraindication for a pleural tap. And this is the positioning, and always it should be an ultrasound guided. Without ultrasound guided, if you do a pleural tap, I think like it's legally not acceptable, and we can be penalized. So always use an ultrasound, localize the fluid where exactly it is, and give an adequate local and put a needle. Preferably, we used to always go for 18 gauge needle, and take a good amount of sample. At least 50 ml of sample should be needed, because we have to send for so much of thing. Just like taking a 10 ml will not be sufficient. You have to see the gross appearance, how it is turbid, pus, or like a hemorrhagic. Hemorrhagic means malignancy, more chance towards malignancy. Straw colored means more towards tubercular. And you have to send the biochemistry, protein, sugar, LDH levels, ADA, culture sensitivity, cell counts, cytology. The cytology, if you want to pick up the malignant cells by cytology, you have to sell at least 20 ml of pleural fluid, at least in 2 containers, for getting the malignant cell positivity. And the pH culture for AB, and triglycerides and chylomicrons in special situations like chylothorax. These are the list of investigations which needs to be sent. And just I'm not going to, because this is beyond in the 20 minutes it will be very difficult to cover all the treatment aspects. So I just going to make the three important conditions what we can do. Antibiotics are the cornerstone for parapneumonic effusions, and the second one being you have to clear the fluid. That you have to go for tube thoracostomy, especially when the pH is acidic or when the glucose is less than 40, and you could able to culture any organisms, and there is a frank pus, or when you see more septations. The septations more you see, you better to drain the with the pleural cavity. And of course, tubercular effusions, ATT being the 4-drug regimen for first 2 months, followed by the 3-drug regimen for the next 4 months, is the one which is routinely recommended. And the role of corticosteroids is usually a controversy thing. We don't really put a steroid for all cases in a tubercular pleural effusions. Very rarely we try to use. It's always a controversy. At this point of, I can say there is not much role for steroids in tuberculous pleural effusions. And malignant effusions, of course, we have to search out the primary and start with the chemotherapy. And when the patient is more symptomatic, you have to go for serial thoracocentesis, sometimes put a chest drain, and you have to do a pleurodesis. Pleurodesis is nothing but desis. Pleuro means pleura, desis means fusion. You have to approximate both the pleura together. So that how you can do it, by putting a chemical agent. We put a chemical called talc, so that it will be approximating each other. There will not be any pleural space for the pleural fluid to get accumulated. So these are about my theoretical stuffs, and just I will be going to some of the how a pulmonologist we can help you out in a difficult cases. I'll be just showing some of the few videos, and with this next 10 minutes I'm going to end this session. This is basically what the scope is there. Thoracoscope is to view the pleural cavity, and this was first performed by a Swedish physician called Jacobius, and he's called as the father of our thoracoscopy. And this being in the hands of pulmonologists, the medical thoracoscopy is right from around in the early 2000 we started doing this thoracoscopy. And it's being like a different from how the surgeon does in cardiothoracic surgeon, because we just do it in a clean procedure room in a simple like a local sedation, local lignocaine plus mild IV sedation, and without much of any anesthetic agents, and it can be even sometimes done as a daycare procedure. So I just want to mean like this is a very simple procedure, and not a like a high-fi procedure which needs more hospital stay. And we have 2 scopes, rigid and semi-rigid scope. This is how the ideal fluoroscopy shoots will be there. Like we have all monitors, and we will be having an ultrasound room, and the indication being like we'll be viewing the pleura for undiagnosed pleural effusions, and to do the pleurodesis, and to drain the pus, especially in complicated parapneumonic effusions. So this is how we position the patient. This is, I'm showing the ultrasound, how I am marking, and I'm looking, this is the fluid, you could able to see the fluid, and just with the help of marking, you should always introduce the needle. So if you like, in the era, like if you are doing a thoracocentesis without an ultrasound, it's actually a, we'll be in trouble. We should not do that. So this is how we position the patient and we give local, and this is how we just drape it very nicely. And this is just like how we put an ICD. We just put a sterile gown all over the region other than the surgical interest, and put a local, and give an incision, like how you do a chest drainage. It's like a simple chest drainage technique. You just give an 1 centimeter incision, and you give a blunt dissection, and thereby introduce the scope. So once you introduce the scope, this is how a normal thoracic cavity will be seen. You could able to see, this is the lung surface, this is the lung surface, this is the what you are seeing is over the repeat, this is the parietal pleural surface. You could able to see the oblique fissure here, and you could able to see the horizontal fissure here, and this is the right lower lobe, and this is the right upper lobe, and this is the right middle lobe. So where we take a biopsy, we usually take the biopsy from the parietal pleural surface or the abnormal regions, and we tend to avoid taking biopsy from the lung parenchyma or the visceral pleural surface. So I'm just going to touch 3 cases. This is a young female who had a fever, pleuritic pain for 3 days, and she was tachypneic, tachycardic, and there was mild basal crepitation head, and the initial X-ray showed a basal patchy pneumonitis, and ultrasound initially showed a minimal effusion. Within 2 days, it progressed to rapidly, almost like the effusion. This is the effusion in the CT. You could able to see it progress rapidly, and we have done a pigtail also, that what this one being seen, the pigtail also being done. However, in spite of that, there was a poor drainage, and we have to go for the thoracoscopy. Just I want to show you how a clean thoracoscopy video I showed. The same, if it is a patient of a parapneumonic effusion, how bad it will be. Like this will be with a lot of agitations, septations. See, suppose with this, like this patient, unless you try to clear it out completely, the patient is not going to improve. So this type of cases, the yearly pulmonology referral is a must for benefiting, for the better benefit of the patients. This once again in another case of parapneumonic effusion. See how bad the pleura being like I mean, like full of septations and lock lesion, both the visceral and the parietal pleura being adherent to each other. Unless you release the visceral pleura, separate the visceral pleura and the parietal pleura completely, the lung will not expand. So this type of complicated cases takes 1 hour procedure, and it may take 3-4 days of hospital stay and adequate antibiotics. But once you do release this completely, we'll be able to get a good lung expansion. So this is how, so the basic, the principles in the complicated parapneumonic effusion is like by thoracoscopy, you do an isolysis, create a single cavity so that the drainage of pus will be facilitated, so that the patient will be having a better outcome. So coming to the next case, this once again a middle-aged male having 2 weeks symptoms of fever, breathlessness, and cough with weight loss. And his initial pleural fluorosis ADA was it was an exudative fluid, but the ADA was only 25. So we are being almost close to 59 years. We don't want to take chances in such type of cases, whether it's a tubercular or malignant effusion. So that was a lymphocytic effusion, ADA was 20. So we decided to go for a thoracoscopy. In the thoracoscopy, we could able to see what I feel in the tubercular effusion, what you feel like is called a sago-grain appearance. Sago-grain appearance is like you could able to see a multiple pleural nodules, multiple small dot like. These nodules are typical of tuberculosis. So this sago-grain, this is the pleural effusion. You could able to see this one, the nodules being whatever the shiny sort of all being the tubercular nodules. I'll just show you a very clear tubercular nodules where it is being seen. You could able to see all these small nodules all over the parietal pleural surface. This is typical what we call as the sago-grain appearance. So this sago-grain appearance, when you see, this is typical of tuberculosis. So once we biopsy this lesion, we'll be able to demonstrate the granulomatous lesion, and this typical and pathognomonic of this tuberculosis. And this just, I'm skipping this case. I'm moving to the next case. So this once again, yeah, 45-year-old female who presented with right side chest pain, and radiologically there was a right pleural effusion as well as mass was seen in the lung. So this one mass in the lung, and there was an effusion. So this was suspicion was malignant effusion. And how I just, the idea of the thoracoscopy, this video is to how the thoracoscopy appearance in the lung. This you could able to see that this is lung. This is actually the tumor, the tumorous lung, how black it is. So this how an unhealthy lung, this is the tumor, and you could able to see some nodules, the large nodules. These nodules are not exactly like the tubercular nodules. The tubercular nodules will be like the smaller nodules, whereas in the malignant one, this one be like a little bit bigger nodules. So we'll be able to see larger nodules in the malignant pleural effusions. So this on biopsy turned out to be, this how we take a biopsy. This on biopsy turned out to be adenocarcinoma. So once again, this one just to show you how sometimes the nodules can be, pleural nodules can be, how big it is. So in the parietal pleural surface, you could able to see a lumpy, bumpy nodules here. When you see this type of nodules, you should not have any like hesitancy. It is an malignant effusion. So these type of effusion, whenever we see, we simultaneously put a powder like that is called a talc powder all over the pleural surface to create a pleuroditic effect, so that the patient will not have recurrent of malignant pleural effusion. So this is a case of malignant effusion. And I'm just skipping this case. So this is one more case. We could able to see last case. This one more case. This the mass is there and effusion is there. I just want to show you the appreciate the video. Here it's a malignant effusion. How the talc being, you could able to see the talc being applied. How it will be viewed thoracoscopically. This is the one. The a special catheter being there, and we could able to spray some over the lung surface. This is basically the talc. So when the talc being applied all over the surface, it creates a inflammatory response over parietal and visceral flora and create a pleuroditic effect. So this is once again a diagrammatic video. Once again, so it's not a picture, how the thoracoscopically the talc being sprayed. So that's it. This is once again not for pleural effusion, but this is how thoracoscopically.
We are running out of time.
Yes, sir.
So can you?
My take-home message, sir.
Yeah, please do.
Yeah, my take-home message means whenever you see an effusion, we should differentiate between a transrate and X-rate effusion. If it is X-rate, definitely it needs further evaluation with the chest X-ray, ultrasound thorax, and pleural fluid analysis. In spite of all the things, evaluation, you couldn't able to diagnose the pleural effusion, that is an undiagnosed pleural effusion, or a complicated parapneumonic effusion, or in lung cancer staging, needs a thoracoscopy, which should be referred to a pulmonologist. Thanks for the patient listening.
Thank you, Dr. Venu. Good treatise and a lucid talk on pleural effusions. I think we have a few questions which has come onto the chat box, and I will go into that. I think all our speakers are present. So I would put questions one by one. That is a few questions. One question on oxygen therapy. What is the ideal method? Dr. Nandagopal?
Yes, sir. Sir, Venu has to stop sharing the screen so that we all can come.
Okay.
Yeah, Venu, please stop sharing the screen.
Yes, sir. Yes.
Yeah, thank you very much. And now, what is the ideal oxygen therapy in a GP's cabin? That is one question.
Okay, sir. Sir, my answer would be to have oxygen concentrator if possible, or it's only a cylinder, sir.
What is the difference between a cylinder and an oxygen concentration? Which one will you prefer and why?
The cylinder will be the first choice because the cylinder can give from 2 liters to around 15 liters. a middle size or a big size cylinder will hold good for at least 2 to 3 hours. Even if you are giving around 10 liters, it should hold good for 30 to 40 minutes. It will be the ideal time before the practitioner can call in the ambulance and the ambulance can come and pick the patient. Because if the patient is going to need 5 or 10 liters oxygen, and if you're going to need the patient, then we can't really treat the patient in the clinic. We have to move the patient to a bigger hospital. The ambulance needs to come. So logically speaking, a cylinder is the first choice. But there are certain practical issues of keeping the cylinder. So in that case, the concentrator, a 10-liter oxygen concentrator would suffice. The only problem with 10-liter oxygen concentrator is that if you are using the concentrator, you can give only up to a maximum of 10 liters, not beyond that. That's number one. Number two is it needs an electricity. So unless the clinic has, if there is a problem of a power failure, then there is always an issue. So these two are the only possibilities in the clinic setup. Other like oxygen tank or liquid oxygen is not possible, sir, in a small clinic.
Thank you, Nandagopal. That is there. I will just add on to that. One thing is that oxygen concentration cylinders are a more practical thing if you want to give more amount of oxygen. So for short periods, it is quite good. But long-term oxygen therapy, we will, because commercially available oxygen that is being served to us, there may be a lot of impurities and one has to be careful about that in long term. As a substitute for short while, it is quite okay. Thank you, Nandagopal. Another question for you is any role for oxygen tent?
Oxygen?
Tent. Oxygen tent being used for giving oxygen.
Denser or tent?
Tent. T-E-N-T, tent.
Tent. So, oxygen tents are being given for more for pediatric age group and in certain other situations. But right now, with the advent of NIV and HFNC, at least I'm not seeing tents being used frequently, sir, except in pediatrics.
Yeah, it is not being used other than in higher centers where hyperbaric oxygens are used.
Oh,
okay.
HPOT is a totally different topic. I didn't think of it, sir, to say.
Okay. I will move on to Dr. Srikanth. Dr.
Sir,
Srikanth.
I don't think Srikanth sir is available, sir.
Is available?
No, I don't think so.
So I will answer for him. That is, I will take up for him. Now, one of the questions that has come is any use of adrenaline in case of an asthma. Adrenaline is a wonderful drug which was used in the past, but it is no more used because of its cardiac side effects. More of cardiac side effects because the availability of nebulizers and other drugs are available. Adrenaline is no more being used. That is what is one of this thing. Then next question, I will move on to Prabhuram. Prabhuram, can you unmute yourself? Prabhuram is not available. Okay, I will leave Nandagopal to answer that. How common overlap of respiratory and cardiac dyspnea? How often you find overlaps?
Sir, no, very often. Often we find the effect would be partially cardiac and partially respiratory, the dyspnea itself. But the thing is, the finer aspect is that we need to evaluate the patient completely as much as possible to define whether the patient is having a cardiac origin for asthma or a respiratory origin.
Okay. I will move on to Dr. Venu. Venu?
Yes, sir. Yes, sir. Available.
There is one question for you. How early to pick up? How early? The question is written like this: how early to pick up pleural effusion in practice? Probably the writer means how early you can pick up pleural effusion in practice.
Sir, if you have a bedside ultrasound, it will be like as low as like even 100 ml or whatever can be picked up in an ultrasound. But Ideally, like a costophrenic angle needs to be blunted when it picked up in an X-ray. I think by the time it will be like the efficient will be, I can say, around close to 200 ml, but at least 150 ml for the CP angle to be blunted, I think. So ultrasound can pick up much more than X-ray. So
ultrasound can pick up even up to 20 ml of fluids. Can be picked up with ultrasound, and less than 100 ml is clinically not able. You cannot detect clinically, and radiologically to pick up this thing, you have to have about 100 to 500 ml of fluid in the chest. So that is what is the answer for that. Anyway, we will move on to Nandagopal again. Nandagopal, oxygen therapy. Oxygen therapy is a must in general and family practice, family medicine practice. Is it a must?
Sir, no, not necessarily, but ideally we should have a backup of oxygen in our practice. Suppose if in case we are giving injections in our cabins, in which case like the Tamil Nadu Clinical Establishment Act clearly differentiates between a consulting room and a clinic. Clinic is where we are supposed to give injections. If you are giving injections, we are supposed to keep emergency drugs with us. So in that case, the oxygen, the need for an oxygen therapy becomes mandatory. So keeping a cylinder would be ideal.
Another question for you, that is intermittent oxygen advisable?
Like we usually advise the long-term oxygen treatment is 16 to 18 hours of oxygen per day. So, and there are certain conditions where we suggest nocturnal oxygen supplementation. So apart from that, I'm not really sure what we mean by an intermittent oxygen. I think you can throw more light on that.
Probably intermittent oxygen is no more used. Earlier, what we used to do was give the patient 1 hour oxygen and take it off for some time. But that concept does not exist. It all depends on keeping the SpO2 above 90%. That is equivalent to 60 mm mercury partial arterial oxygen pressure. So that has to be maintained for a sustained period of time. And usually long-term oxygen therapy recommendation is minimum 14 hours onwards to 18 hours. If the patient is not able to sustain life, even without that, in that case, more or less continuous oxygen has to be given to the patient. There is no role for intermittent oxygen that is what I believe in. Now, I will move on to Venugopal.
Yes, sir.
How safe is it to use steroids in exudative effusion to prevent absorption and adhesions, to prevent adhesions and to facilitate absorption? Is there any role?
Steroids, no role for any like a bacterial pleural effusion, completely no role. Even tubercular effusion also no definite role. But maybe still I can say is a controversial role. In a selected cases, we can go for a low dose of prednisolone in tubercular pleural effusion to prevent the pleural thickening. But still, but that's a controversy, sir. I can say at this point of time, not great role in only TB pericarditis. There is a role. TB pleural effusion, not much role for steroids.
Actually, as per guidelines, there is no recommendation to use steroids in pleural effusions unless otherwise there is any other indication for that. Earlier, when I was a PG student, we used to regularly give steroids along with ATT to tuberculosis patients, and then slowly we used to taper it off. But presently, there has been trials and papers which have shown that there is absolutely no difference between pleural effusion treated with steroid and without steroid, especially in tuberculosis. Excuse me, can you unmute yourself, please? Somebody is talking. Somebody is talking. I don't know who. Anyway, so role of steroid is off. Nandagopal,
Yes, sir.
is there any suggestions? One question from Dr. Meena. She has asked that oxygen therapy in interstitial lung disease. Is there anything you have to say about? That is the only thing she has asked.
Yes, sir. Sir, oxygen therapy in interstitial lung disease is recommended whenever the patient's baseline oxygen saturation is below 90%. SpO2 goes below 90%. Till that time, I think you can wait. But there are certain guidelines which suggest that even below 94, we have to start. But in India, because we have a cost angle also into it, then we wait till around SpO2 becomes 90. So if there's a hypoxemic respiratory failure associated with an ILD, then we have to give oxygen support.
Okay, thank you. I'll move on to Venu.
Yes, sir.
You have to answer something on dyspnea. What is your opinion on dyspnea at rest and dyspnea on exertion? Is there any difference? Very non-specific question.
See, dyspnea at rest and dyspnea on exertion. So yeah, dyspnea at rest means basically it indicates more the severity of dyspnea is more. So that dyspnea on exertion could be like we can grade from MMRC like how much they're able to make 100 meters or like wake with one space. We can grade the dyspnea on exertion based on that. So it's dyspnea on exertion to dyspnea at rest. It's a grading of dyspnea. Like dyspnea at rest means the patient is being more severe dyspneic, and so I think I couldn't able to understand the question.
No. This question is opinion on dyspnea at rest and dyspnea on exertion. Actually, dyspnea is dyspnea, whether it is in rest or it is in exertion. So in rest, what happens is the patient, you have to find out the cause and treat the dyspnea. That is the only answer I can give.
Sir,
anyway,
just I can add a point, sir. Could I add a point
maybe
here?
orthopnea. Maybe he was adding orthopnea. If you have an orthopnea,
Yeah, exactly.
At rest, we have to consider cardiac causes. So that is one thing we can add, especially at the rest when lying down. He has a dyspnea, orthopnea. We have to consider cardiac causes.
Okay. Now, one more question. I'll continue with you, Venu. Be there. What are the other agents other than talc you use for fluorodesis?
Yeah, the simple, easily available agent is povidone iodine. Povidone iodine we use like 10% povidone iodine, 20 ml diluted with 50 ml saline. We can even give it to the ICD itself. Then bleomycin can be used and tetracycline can be used. And these are the commonly we use the things. And talc itself can be made as a like a slurry form and can be used. So povidone iodine and bleomycin and tetracycline, silver nitrates, but we don't use this. I never use silver nitrate. Tetracycline and bleomycin, povidone iodine we commonly use.
What about patient's own blood?
Sir, patient's own blood, yeah, that is autologous blood patch fluorodesis. Sir, that is being more practiced for broncho any fistula, sir. I feel like when they have the bronchopleural something like fistula that can seal the fistula, something that can be tried, but I don't have any experience on it, sir.
Okay. Now regarding the sense, I'll come back to you later. Let us move on to asthma. There are some questions. Is there any difference between asthma therapy in male and female patients? Nandagopal?
Sir, I'm not really sure. The guidelines don't suggest any differences.
Outcome of asthma therapy in male and female patients.
Maybe
is there any problem?
Outcomes, there may be a slight difference in considering the exposure. So if it's an occupational exposure related, and if there is a home exposure, inside home exposure, then there could be a gender differences. But as far as the therapy is concerned, I'm not sure if there are any, as per guidelines, there are no differences, sir.
I think you are right. There is no differences between a male and female asthma. Now, another question one Dr. Gauri has asked, that is, what is the ideal nebulizer technique? Ideal nebulizer technique, I think what she feels is whether to use a mask or to use a mouthpiece. Can you elaborate on that?
Sir, there is nothing like even for an inhalational medicine, there is nothing like an ideal device for which one size fits all. It depends on that person's capabilities or the patient's capabilities. So, if they are using a mask, there is always a better chance of taking it inhalationally. But when they're using a mouthpiece, they have to take in slightly deeper. That's how I perceive it. But I'm not really sure. Is there any technical difference, sir? Probably you would be able to elaborate. I haven't thought it that way.
No, one thing is that mouthpieces deliver much better than masks in general. But mouthpieces are difficult for patient to hold on to the mouth when they are really sick. That is one. Another thing is when you are using a mask, it is better to keep the mouth open and breathe through the mouth. The delivery is much better. When there is they breathe through the nose because of the nasal hair and the deviated nasal septum, and at times there are hypertrophic turbinates and all that. Usually what happens is there may be a delay in what happened. Am I audible?
Sir, you're audible, sir. Your video is frozen.
Video is frozen. I don't know what happened to this. Anyway, I will go on continue. Am I audible now?
Yes, sir. Yes, sir. You are audible, sir.
So what happens is you have to keep your mouth open. The delivery is much better. And that is the only thing. Otherwise, there is the difference between a device and a nebulizer is devices you have to give, you have to use a technique. Here, there is no technique is needed. Patient can have with their tidal breathing, or if you want to deliver more, intermittent extra breaths can be taken. Now, one question
sir,
that has been asked.
Sir, just one more point, sir. If there are any anticholinergics being used, like the contact with the eye, it should be lesser. So in that case, mouthpiece is better.
Mouthpiece is much better. So one of the side effects of using an anticholinergic is mydriasis, blurring of vision. That has to be kept in mind.
Worsening of glaucoma.
Venu, can you answer this? Impact of COVID in asthmatics.
As like any viral pneumonia can be an predisposing factor for exacerbations. Even the mild COVID was having a more exacerbations for asthmatics, and of course, and these patients were not asthmatics and COPD. They become to tend more sicker because of their poor pulmonary reserve, and they tend to deteriorate when it becomes the disease becomes worsened. So always like still we do see some patchy cases of COVID then and there, like monthly once or something. So I feel like the still COVID is not completely off, and still we have to think of the things when it is when the clinical scenario fits in.
No, I think the person who has asked this question means that during our COVID period, it was strangely we saw that incidence of asthma had come down considerably. Incidence. I mean, the patients reporting with acute exacerbations. Probably that was because of the use of mask and lesser of other viral infections. COVID was predominating. Probably that could be the answer. But otherwise, as any other viral infection, COVID can also exacerbate an asthma. I think we will go to another question. How common is late onset asthma in your practice? Venu can answer or Nandagopal?
Sir, we do see, but as pulmonologists, when we see late onset asthmatics, when we say that, it could be skewed because we see more of asthma and COPD in our practice. But any late onset asthma has to be differentiated. Like Prabhuram was telling, we have to evaluate for dyspnea on a more broader setting, and we have to come to conclusion. We also need to exclude any occupational exposures so that it could be a COPD, not an asthma.
Venu, I have got another question. Are you hearing me?
Sir, can I intervene, sir? 2 minutes.
Yeah, please do.
Yes, sir. Sir, actually, I'm sorry to intervene. Maybe we'll take this as a last question, sir, because the same Zoom platform is being used for the next class at 7 o'clock. So they are
Okay.
to
So
wind
there
it down because it is
I have other
already.
few questions, but I will. I think
Yes,
the major questions has been answered. Thank you very much. I will close it right away. Thank you very much.
Thank you, sir. Sorry for the
Thank you.
intervention, and I also request Dr. Nandagopal sir to elaborate on our courses, sir. Our fellowship course we are starting shortly, no, sir. You can say a few words regarding that, because people are there.
May I just add one more point? That is one of our participants has requested.
Yes, sir, definitely, sir. After that, Nandagopal sir will elaborate on this, sir. Thank you, sir.
Can we get the slides for our referral? That is what they have asked. That is your ball is in your court.
Sir, we have recorded all those things, sir. We'll post it, sir. And when the whole 5 days conference is over, sir, we'll definitely do it, sir. That's not an issue, sir.
Thank you. Thank you very much.
Sir, Nandagopal sir.
Yeah, thank you. Good evening. Good evening to everyone. Thanks for a patient listening. I can see that even at 7:15 or 7:20, there are more than 400 participants. It's very glad to see that kind of a number in an IMA platform. As Dr. Anand had already said, there are more than 800 participants every day. And even today, I think it's touched more than 600 at times. So to come back to the point that we are conducting a respiratory course for general practitioners, which is basically covering the entire spectrum of respiratory diseases, which will help in their practice. It's a more of an update covering from tuberculosis to asthma to COPD to other respiratory infections. What is the latest practice? What is the latest recommendations? What are the newer investigation modalities available? What are the newer algorithms which come into the practice? So it will be a refreshing course because most of the patients who come to our general practice are respiratory. I think at least the majority of the cases will be respiratory in nature. If I'm not wrong, if you have to divide the cases into system wise, it will be respiratory. So probably we can all benefit from that. So you are welcome to join this knowledge sharing course over a period of 6 months. It will be around 12 or 18 contact classes as devised by Dr. Bomusamy. So this year, Dr. Bomusamy is taking over as the de facto course director because I'm a little busy with the NAPCON work. So please, I again welcome every one of you to join the respiratory course run by the CGP in a very efficient way over the last 4 or 5 years. Welcome. Thank you.
Sir, thank you for the update, sir. And for the participants, we will post it in the groups, like what is the eligibility criteria, all those things. Basically, you need to be an IMA Life member and a CGP member. So that's it. And now I request our Assistant Secretary, Dr. Vivek, to propose the vote of thanks. Dr. Vivek?
Yes, thank you, sir. So, what a session we had today, a brainstorming session for all the participants who had attended this event. I take this opportunity to thank the State President, Dr. Abul Hassan, sir, State Secretary, Karthik Prabhu, sir, and State Treasurer in this giving a chance for the CGP to do this event. And I would like to thank Rajesh Sengodan, sir, for giving the IMA prayer and physician prayer in the evening. I like to thank Dr. Sendil, CGP Chairman, for giving the welcome address for us today. I would like to thank Dr. Anand Chokalingam, Secretary CGP, who is the backbone of all these 5 days, who has been doing an excellent job for this 5 days. And I would like to thank Tiruvem Mohan sir for felicitating the event today. He is the Joint Secretary of CGP National IMA. And I would like to thank Dr. Chandrasekhar for giving a felicitation talk and encouraging all the participants today. And he is the Vice President of West Zone IMA for the year 2024. And I would like to thank Dr. Jay Mohan sir for moderating today's session in a wonderful way and making all the doubts getting cleared, which were being typed in the chat box. And I would like to thank the stalwarts today, the first speaker Nandagopal sir, for giving the patient talk and also clearing all the doubts for everybody. And I would like to thank the second speaker, Srikant Krishnamurthy sir, for giving his talk on asthma management. And I would like to thank Dr. Prabhuram sir, the third speaker, for speaking about dyspnea for evaluation. And at last, after so many technical glitches, we had our fourth speaker, Venugopal sir, for giving his pearls in pleural effusion. And I would like to thank all the participants for attending this event. Without you, this event is not a grand success. At times, we reached around 700 also today. So that is a huge success, and many people were interested in hearing and asking questions also. So I would like to thank all the participants today and for the previous days also who have attended the Zoom meeting. And I would like to welcome you for tomorrow's physical meeting at IMA Polachi. And that is going to be a hybrid one. There is going to be a physical meeting and a Zoom meeting also tomorrow. So I would like to thank all the participants and speakers for giving this wonderful opportunity to give the vote of thanks for today's event. Thank you, sir.
Thank you.
Thank you, Dr. So we'll call it a day, sir. Thank you, Nandagopal sir. Thank you, sir. Thank you, sir.
Thank you. Thank you.